Wonderful presentations. I think it's time to start with our first session. I'm calling the chairs, Malena Cohen-Simbeknoch, Andrea Vukic-Dugac, Irma Tashi, and Tatiana Mareti. Thank you.
Hello. Now we will start with our morning session. It's nice to see you that you come in so huge number. And I will start with the presentation of our first presenter. It's Malena Cohen from Israel, and she will speak something about what is important for adult CF management.
Thank you very much. Good morning, and it's my honor to be here. Thank you to the organizers, Katarina and Dr. Pavel, to invited me to be a speaker. And I want to start my first presentation, and I will speak about evolving perspectives in adult CF management and multidisciplinary approach. So let's start from the beginning. In the 16th century, the first accurate description of a swollen, hardened, and gleaming pancreas, likely due to cystic fibrosis, was documented in an autopsy report of an 11-year-old girl once believed to be bewitched. Later on, the report states that if it tastes salty when someone is kissed on the brow, then this person is exit. Later on, they wrote that the child will soon die whose brow tastes salty when kissed. Only in 1938, Dorothy Anderson first recognized cystic fibrosis as a specific entity. So we all know that there are different research milestones since this first report in 1938. In 1953, the sweat chloride defect was connected with cystic fibrosis. In 1989, the CFTR gene was finally discovered, and since then, a lot of milestones were achieved. Now we are in a new era of the CFTR modulators, and we are in the area of personalized medicine by organoids. And mRNA therapy trials are ongoing for people who cannot be treated by the CFTR modulators. So cystic fibrosis is no longer a kid's disease. Previously, patients died in early infancy. The adults is the new phase of cystic fibrosis. And for those who was born after 2000, the CFF data estimate a survival of about 60 years old. The advances in diagnosis and specifically in CF care are largely responsible for the improved lifespan in people with CF. So this is from the ECFF patient registry. We saw it yesterday, and you can see here that in the Europe registry, more than 50% of the patients are adults. It's different between the different, It's different between the different countries. You can see here the second one is Israel. We have a high proportion of adult patients. More than 70% of our population are adults. Currently, people with CF live longer and live better. Not just there is an improvement in survival, but they have better quality of life. They do more exercise. More people with CF decide to create a family, more pregnancies, but more complications which are related to age. Aging with CF is a new topic. cancer, and more pathologies. So adult CF care is increasingly complex. That's what we have to treat our patients by a multidisciplinary team. We know that the CF includes not only lung disease or sinus disease and sweat glands disease, but also in CF it's affected the pancreas, the gastrointestinal tract, the reproductive system, the lungs. But we have more and more in adults, the incidence of CFRD, CF-related diabetes, is increasing with age, GI cancer, osteopenia, osteoporosis, and of course, more and more anxiety and depression in the adult population. So this is one of our patients, the oldest patient in our clinic. He's almost 80 years old today, Ami. But Ami suffered not just for CF, but he has another diseases related to the age. We reported that Ami have CF that was diagnosed at the age of 37. He has actually moderate to severe lung disease. He has pancreatic insufficiency, diabetes, chronic MRSA and Pseudomonas infection, hypertension, hyperlipidemia, and more diseases. So it's very important that there are some adverse effects in people with CF, in adults with CF, because they receive a lot of medications. This is another report that was recently published from our center. This is a 35-year-old man with a mild and stable cystic fibrosis who was presented with a severe respiratory distress, a kind of pulmonary exacerbation, but atypical. A lung mass and pleural effusion were diagnosed, and finally he was diagnosed with small cell lung carcinoma. So it's important to remember that people with CF can, in concomitant, have another diseases related to the adulthood. And we know that people with CF also suffer from cancer, and it's important to diagnose people with CF. We know that GI cancer, especially colorectal cancer, is 5 to 10 times higher in people with CF compared to general population. So small bowel, pancreatic, and biliary tract also show increased incidence in people with CF. Cervical and breast cancer, they have no specific recommendations for people with CF, but it's important to check all of our adult patients with CF. These are some pictures that reveal that in 1940, these were people with the cystic fibrosis, and later on in the 80s. But now we have a different picture of people with CF. This is Dudi, one of my patients. He suffered from CF with a pancreatic insufficiency. He was twice transplanted. He has liver transplant. And this is Dudi in 2018, before he started with Trikafta. This is Dudi today. He was married, and hopefully Dudi is the new form, the new norm of cystic fibrosis and not the exception. Thank you very much for your attention.
Thank you very much, Doctor. It was really a nice and interesting presentation. Now we are going to listen to Dr. Vukic, which will show us the key steps for the success of building an adult CF center. Thank you.
Good morning. It's nice to be with you today. So, as an adult pulmonologist, I will try to give you answer on the question what you need to build a successful adult CF center. So, everybody started with this slide. I don't know. It's very important to emphasize that from the first clinical description of cystic fibrosis to the discovery of CFTR modulators have passed more than 80 years, and many significant progress was achieved regarding treatment and diagnosis of cystic fibrosis. Of course, establishment of CF centers and standards of care have played a key role in improvement of lives patients with cystic fibrosis. And thanks to all this achievement today, we no longer see children who will die in the first year, and also we hopefully will see more elderly patients in the future. So, if we speak about older or adult patients with cystic fibrosis, we know that as a result of better understanding of cystic fibrosis, significant improvements in treatment, standards of care, and approach and multidisciplinary approach to our patient resulted with a growing number of adult patients with cystic fibrosis, and the need to build the dedicated adult CF center was increased. So we know that it's not easy to build an adult CF center, especially in the past, because we have a lot of challenges at that period because the number of patients was higher, but at that same time, transition limited access was to adult caregivers. It was a lack of training and funding, it was lack of facilities, and also we didn't have a multidisciplinary team in adult CF services, and of course something new come in adult hospital. So this need to build adult CF center was recognized, and in a joint meeting, the joint meeting of World Health Organization, International CF Association, and Patient International Adult CF Association was organized in Hague in 1999. And the conclusions from this joint meeting was presented in this meeting report in Journal of Cystic Fibrosis in 1999. In 2002, sorry. So in this report, they tried to give us some recommendation regarding provision of adult medical and associated service for adult patients. Of course, they tried to give us some information, what you need for the transition, what components of adult CF center should be, and about patterns of healthcare delivery, about training, and so on. So I will go just through the main topics from this report. They pointed what the need for multidisciplinary care in adult CF services. They emphasized importance of required team members. You know that this is a core team of each CF center. They try to give us some information what is need for proper facilities in adult CF center, and also they highlights importance of independent adult CF centers, and of course about how important is education of adult CF physician. So at that time, in 2002, in Croatia, we didn't have any adult CF center. At that time, we even didn't have so much adult patients. Most of our patients were under 18. Most of our patients were controlled in different hospitals, pediatrics hospital in Croatia, and most of them at University Hospital of Zagreb. And at that time, we can really say that cystic fibrosis in Croatia was still a childhood disease. So 10, 15 years later, report of the European Respiratory Society and Respiratory Cystic Fibrosis Society Task Force was published in European Respiratory Journal, and they showed what we know, that the number of adult patients was growing, and that in most of countries in Europe, but also in UK, Canada, Australia, the percentage of adult patients was higher than the percentage of pediatrician patients. So they tried to give us some highlights, everything what we now know about adult patients with cystic fibrosis, that these patients are patients who have a higher morbidity, more comorbidities, more complications, they have specific needs, psychological, more problem with adherence, and they need more frequently lung transplantation program and end-of-life care. So they also try to give us some recommendation about organization and the number of consultants in CF centers, adult CF centers, regarding the number of adult patients. So at that time, they tried to see what is the situation, because from the first report to this, almost 15 years passed, and they wanted to see what is the situation in adult CF service at that time, in 2017. So the SUMED with the colleagues made and organized online survey to see what is the situation in, regarding adult CF patient. And this survey showed that still almost 95% of adult patients have access to adult pulmonologists, but still almost 70% also was seen by pediatrician, and more than 50% of adult patients was still admitted to a pediatrician ward during acute exacerbation of cystic fibrosis. So situation wasn't perfect. So what we see now, we will see what happened in Croatia and that time during these 15 years. So you can see that the number of adult patients was increasing in Croatia, and especially number of adult patients who need lung transplantation. At that time, in Croatia, we started with our lung transplantation program. So in Clinic for Respiratory Diseases, Jordanovac, we started with collaboration, in collaboration with University Hospital of Wien in Austria. In 2011, we started with our lung transplantation program. This program was organized on that way that pre- and post-lung transplantation care for our patient was organized in our hospital. The surgical procedure of lung transplantation was organized in Austria. From 2021, complete lung transplantation program in Croatia is in our clinic. So the first lung transplantation in cystic fibrosis patient in Croatia was in that year, in 2011. And we can say that was the first proper transition of adult CF patient from pediatric to adult world, and from this period, in different stages, we started with transition. In the first stage, as I said, that was a patient with, who needed a lung transplantation. In the next stage, it was an adult CF patient with some difficulties and complications. And from 2015, we started with transition of stable adult patient with cystic fibrosis. So this year we take as a year when we established our adult CF team, and from 2017 we started work of multidisciplinary team, and we established our Cystic Fibrosis Center for children and adults. So when we discuss about what you need about lung transplantation program, because we started firstly with our lung transplantation program, you see that you need more or less the same things what you need for successful adult CF center. You need, of course, education of physician, you need pulmonary rehabilitation program, you need psychologists, you need a nutritionist, you need facilities, single room, and patient segregation. So more or less the same things what you need for a successful adult CF center. So that was our beginning. It was easier to go further. But if you ask me what is the most important things what you need for successful adult CF center, I will say these three. The first one is the leadership. You need a leader in your hospital who has a motivation, who has a vision, who has idea what you need, and he wants some progress regarding care of patient. The second one, very important component, is dedicated physician. So on the previous slide, when we go through the timeline in Croatian building of a CF center, you see that our pediatrician started with the initiative for establishment of adult CF center in the early 2000s. But they need almost 20 years to find a person who wants to do really with a patient with cystic fibrosis. I'm a pulmonologist, and most of you are pulmonologists, so you know that it's not easy to work with a multisystemic disease such as cystic fibrosis. You need a lot of knowledge, not only from pulmonology, but from gastroenterology. You need to be a little bit psychologist, so it's not easy. So I will just emphasize this sentence from the joint meeting from Hague, where they said motivation, commitment, and dedication of time by the team are more important than any other consideration. And from my opinion, the most important, what was for building our CF center, was partnership between pulmonologist and pediatrician. From early beginning of our work, we were working together, we communicate a lot, and today we really work as one team. So I think that it's the most important. So during these 10 and more years, I believe, manage a lot. We became a part of patient registry. We organized first a multidisciplinary team. We educate not only physicians, but also CF nurses. And also during the COVID, we finally, in our hospital, get specific facilities only for outpatient part of adult CF center. So I'm more than proud on our adult CF center in Croatia today. We have almost 70 adult CF patients, and we take care for all adult patients in Croatia. So in the future, still the problem isn't resolved regarding adult CF center. We still have a lot of problems. As you know, in many countries, we still don't have adult CF center. All the number of adult center is not enough. And still we have to discuss about standards of care in adult CF center, and we still discuss about educational gaps in these centers. So today we should cope in adult CF centers with specific needs. You know that aging burden is something what already happened. Regarding CFTR modulators, the patient have new problems. We have now more patients with cardiovascular diseases, metabolic syndrome, malignancy, and we will see what will future give us. So in the past, the problem was that we wanted to fit adult patient in the shoes of pediatric center because we didn't have adult CF centers. But I think that in the future, we need to think and to redefine completely CF care in adult and pediatrician world as well. And instead of conclusion, I will finish my talk with the photo of our CF center. And I think at the end that I maybe didn't speak and show you so much slides, and I maybe just should show you this picture, because the answer on this question is really these people. Thank you very much.
Congratulations for your work and your very nice presentation. Thank you. Okay, so now I want to present Dr. Irma Tashi from Albania. She will speak about treating adult CF patients in Albania. Thank you.
Good morning to everyone again. Now I'm going to speak about treating adults in Albania, as we are a new CF center adults created in Albania, which, as I told you yesterday, the treatment of cystic fibrosis in adults has gained focus since 2022 with the opening of the cystic fibrosis clinic. Patients are followed in our clinic and in our center in two directions: periodic follow-up and exacerbation. I must emphasize that the collaboration with pediatrics has been strong and really good regarding the initial information of these patients. Now, I'm going to show you what is the situation in Albania regarding the reimbursement medication of adult cystic fibrosis patient. We must emphasize that we have reimbursed the oral ursodeoxycholic acid, oral pancreatic enzymes, inhaled bronchodilators, inhaled steroids, oral microlides, but partially reimbursed, oral antibiotics, also these partially reimbursed, and oral proton pump inhibitors. But what is our difficulties and the things that we are going through in the following up of these patients? Because we are in lack of vitamins, in devices, we are in lack on inhaled hypertonic saline, on inhaled mannitol oxygenotherapy in home, inhaled eridinase, inhaled tobramycin, and most of all of modulator. So as we all see here, we have really a great lack and, of medication and on treating on really cystic fibrosis patient. But we might say that we help and we try to discuss and to educate mostly our patient, the adult patient, because the transition, as I told you yesterday, from pediatric to adults is that they should really aware of their disease. And we have visits according to the referral systems every 6 months, respiratory tests that are performed in our hospital every 6 months, lung CT scan every year, sputum examination, antibiogram every 6 months, but it is self-funded from the patient, direct phone consultation for patients and families, and annual consultation with endocrinologists and gastroenterologists. Regarding the exacerbation, the patient are hospitalized and supportive therapy is started. We have actually in our hospitals the IV antibiotics like colistin, and we try also to use it as nebulized, but only in hospitalized patients. Consultation and exercises with physiotherapists, and treatment is evaluated from endocrinologists, cardiologists, gastropatologists, and rheumatologists that we have in our hospital. We must say that we do not have a nutritionist and a psychologist. Now, in this slide, which is the end of my presentation, I must say that what to be done. We have discussed yesterday regarding, the CF organization of the patient, regarding our duty as doctors, but we must say that first of all, we need to educate them and ourselves, and then to treat. And I must say that together we can. We need to collaborate strongly with our patient and patient with us, and none of us, only us, we can manage to win this fight. So as a new center, almost a newly center here representing, I must say that next year we will have a great and really much achievements to show. Thank you.
Great presentation. Now we are going for another lecture. Please, Dr. Marlena. This one with Duška Tješić. I cannot read it because I'm with lenses. Yes.
So, Dr. Duška
Brinković.
Yes,
It's easier.
as you said. She will present about transition from children to adult CF center.
Yes, thank you for the announcement, and hello everyone again. Greetings from Zagreb, from the capital of Croatia, where I work together with Andrea. What? This? You hear me? Yes, I suppose. Okay, let's start. Of course, all of us know that we can discuss transition as a theme only because we do not speak about cystic fibrosis in this manner anymore, so it is not a deadly disease in early years. And actually, some calculations, some statistical reviews, very nicely conducted in 2023, showed that even without modulators, so these are these yellow bars, we expect our patients to live quite long, and the median expectant life expectancy would be around 40 years or above that for those groups of patients. And for those who have treatment with modulators early, the earlier we expect them to have, these are the red ones, we expect them to have actually a lifespan which would be totally comparable with the adult, with the general population in some surroundings. So yes, this is very promising, but what is the real situation now? Where we are getting there, this is the Americans, they have about 60% or more of adult patients, and this slide we have already seen. So in Europe, the last report says 52% of adult patients. But we must not get fooled with this slide, because the patients here in this slide are not very coherent. Why? Because the number of countries participating in the registry has increased immensely from the beginning. It is 20 countries more. So it means that this is a very heterogeneous population, and this is also shown earlier. yes, in general, 52% of Europeans patients are adults, but for many countries it is still not the case. And as you remember yesterday, Lutz emphasized that those on the right side, so those who have a lot of yellow bars, these are the mentee countries mostly, and the mentors are on the left side. However, it is obvious that everyone has to transit, and that even all those patients who are now children in the mentees countries, the mentees have to start their programs of transition early because it takes time, and they will achieve the adulthood. Many of their patients will achieve adulthood quite soon or in many years. But the challenges are definitely different. That doesn't mean that the so developed ones don't have their challenges. This is the definition of transition. So it is a purposeful and planned movement of adolescents with chronic diseases from childhood health care to the adult healthcare system, and that includes gradual taking responsibility, actually moving the responsibility from the parents to the patients themselves as they develop to adulthood. It happens in adolescence, and as we all know, adolescence is a very, very tricky period. It's a period which is not defined by a year, and somewhere within this age gap of the adolescence, you will gain your legal age, but that doesn't actually mean that you are mature, as we all know. And also, it comprehends every possible way of maturation, so in the field of physical maturation, psychological, social, emotional, moral maturation. And it is certainly so that if you are a patient with a chronic disease, any chronic disease, and maybe cystic fibrosis specifically, that just the fact that you have the disease will make achieving these goals during adolescence even more demanding and more challenging. CF, this is a reminder how CF is really a complex disease, how it is a progressive disease, and how we expect with time the numbers of comorbidities and clinical manifestations of the disease to increase. This is for those who are not on modulators, so these are for those people who have been born with CF and are treated with the standard care, as we know. Actually, we don't know how this slide would look in the era of modulators when we have a lot of people with the disease that is changing in a different way and presenting with new and different manifestations. We know from the past, and this is also a quite old slide, that transition can be simple or more complicated, and that many features of the disease are features that complicate transition. And cystic fibrosis, unfortunately, has basically all of those, or almost all of those features on the right side, so of a more complex disease. First of all, because it is really a multisystemic disease, but then also because of all of these items that are written here on this slide. So yes, if we have a cystic fibrosis patient and he's an adolescent and he's transitioning, really this can be a really stormy pathway, and we must be aware of that and try to assist our patients to get through this quite nicely and with as little damage as possible. We know that the surroundings in which our patients are treated is totally different in the pediatric and the adult ward. So it is not just because they have different CF manifestations, but it is because we always address the family as a whole, as an item, as a whole unit we are talking to in the pediatric ward. We take relative information from the parents, and we are mainly focused on preventing disease development and progression, and maintaining and securing that the development and the growth of the patient will be as much as possible within the normal ranges. Of course, in the adult center, the adult physicians are oriented to the adult patient themselves. They encourage independence and making decisions on the regard of the patients by themselves. And of course, you have many different issues which are not pediatric issues, like sexuality, like finances, employment, marriage, etc. So it is quite normal that these issues cannot be met and addressed properly in a pediatric surrounding, which is basically very nurturing and protective. And therefore, at what time it is imminent that they do pass to the adult care, and it is our duty to make it possible and make it without many disturbances. We must not mix transfer and transition. This is very important because transition is a stepwise seduction of certain steps which finally will lead to the transfer, and the transfer is just one moment, a handover of the patient from the pediatric to the adult health care. And as the sooner this is one step in the transition process, and the sooner this step comes, the earlier age it comes, that means that more of the transition process and leading should be held on with the adult ward. If this is not the case, if we just transfer our patient without these prior things, then we have many hazards of this. Hazards, first of all, you usually have a too long a gap between the pediatric team consultation and the adult doctor consultation. You have poor adherence, you don't have trustful relationships, the disease worsens, etc., etc. So to overcome that, you have to have a plan, and this plan lasts for a long time. You see, it's here for 10 years, in which this responsibility is slowly diverted from the parents toward the patient themselves, and still the parents do have a role at the end of this process when you have an adult patient, but the role is supportive and not the leadership in management as it is at the beginning of the process. So a successful transition means that you will have, for the patient, continued care, which is uninterrupted during the same manners, and that it will be not only medically appropriate, but also appropriate to the age of your patient. That is very important, and that you will be able to build, with the patient will be able to build trustful relationships with the adult CF team. And only in that way we can really maximize the future of our patients, meaning that we will secure them a lifelong functioning and a well-being for them. Best practice with tradition, well, one does not fit all, and of course there are many problems different in different surroundings, but there is something that is for certain that you need. You need to have a dedicated adult team, as we already heard many times. So even when you have a very small population of adults, the goal is to try to motivate an adult unit to find a dedicated, first of all, pulmonologist who will be willing to take over the patients. And once when you have a dedicated pediatrician and a dedicated adult doctor, then the communication is really important. You have to communicate all the time. You have to agree on the process of transition and little milestones, several milestones which have to be achieved, and see how that works through time. As I said, best practice does not exist, and the approach depends on several things, as you have see here, and it is very individual for every surrounding. But what is unique for all the surroundings is that you have barriers, and these barriers arise from certain concerns and uncertainties from the patients, from the parents, and from both the pediatric and adult healthcare system. And it is impossible here to go into details, but I must say that from what I see from praxis, usually more barriers come from the parents than from the patient themselves. They are not that reluctant as the parents are. Usually the fear among the parents is greater. And also, there can be many discussions with the pediatricians and with the barriers regarding the adult care providers. But surveys have shown that only if you do not have a process, a real good process, you will not be able to surpass these problems. So the most evident barrier is not having a process. And that you need to have a process is known quite long ago. Even in the 90s, the Cystic Fibrosis Foundation in America advocated this, and this was published in 2011. So these are the 6 core steps which have to be, which you have to go through if you want to have a successful transition. However, although we know about this for a long time, some surveys regarding how this is implemented are not so good. So in 2022, the last survey in America says that only 20% of the patients with special care needs did go through and did get support through the system while transitioning. The numbers are a little bit higher for CF, but not high enough. And this is because the problem of transition has been, let's say, longer stressed in CF as a community. There is little consensus on how to best organize the CF transition, but luckily the CF community does have some tools. These are free online tools. They are all in English or in French also for the Canadian one, and there are many others which can help you in this process of organizing transition. And these programs are meant for healthcare providers, for parents, and for patients. Also, the last standards of care of the European Cystic Fibrosis Society addresses transition as an important problem and assisting patients during this. And they also offer several links which could be helpful for everyone participating. Parents in transition are the family, the doctors from the pediatric, the pediatric team, the adult team, and also the healthcare provider. So it is a teamwork, we are partners, but the responsibility that it goes smoothly lies on us, on healthcare professionals, and that should be known. We work around the patient and we try to meet their needs mainly. And actually, we have to guide them. We have to see in advance to recognize the problems which will come and help them overcome them. That is the core of a good transition. And it takes time and it takes experience. So these are the steps. The steps from the beginning when the child is totally dependent on the parent, but make no mistake, even very young children know something about their disease. You know that preschool children will take their enzymes with the meal and they will refuse the meal if they don't have enzymes. So they already, in the preschool ages, know something about the disease. And this knowledge has to increase accordingly to their age and their capability. And here are the steps which we are, not, of course, not going through all the time, all the milestones. And this is not so age-specific. It depends on the development of the child, the other spheres of the child development. But it is on the team to help the parents recognize what is their role in this and to help them achieve this role. So at the end, they will just be in the supportive role and the leadership of management will rely on the independent patient themselves. No rule, no recipe for a successful transition, but yes, some tips we can give. First of all, it is never too early to announce transition. From the first day, we should tell that cystic fibrosis is not a disease where you expect to die early, but you do look forward to the adulthood. And of course, the main process of transiting will start at the adulthood. A transition plan should be always in place, and the transition team consists of both people from the pediatric and from the adult team, and there should be one coordinator. Usually it's a nurse, but not necessarily a nurse. And only with that way you can recognize problems during transition and help overcome those problems. During this process, how the child has assessed, how it is ready to, how the readiness of the child should be assessed periodically, and this is not testing. It should be not presented as testing, but as actually helping the child to get better knowledge and better skills over their own disease. This meet and greet was recognized by the patients as one of the most important steps for a successful transition program. That means that the adult healthcare providers are met far earlier than the transfer itself occurs. Ideally in the pediatric surrounding, because this is the surrounding which the patient is familiar with, and that gives great reassurance to the patient to know that the teams are well coordinated and that they will have still access to their pediatric doctors and the team if they need it. And also it is good if they could meet and hear some experiences for some patients who have already gone through the transition program. The time of transition, that should be flexible. However, that is not always the case, because in many surroundings, the chronologic age is actually that criteria which is used for transition. Although, as you see, the real-life experience says that you have a very high range of the time when patients transit. Usually it is between the years 16 and 21, but not always that way. And one must be aware that readiness for transition or eligibility for transitions are not the same, so we must think about that when we transit our patients. The transfer of documents is very important. It should be a summary, and not only for the doctors, but also for the nurses, for the physios, for everybody involved in the care. And apart from medical data, it should have some data on the background of the patient, the social circumstances, the educational, some personal issues. This is always good. And maybe it will come as a surprise, but it has been shown that the best way, the most effective way, is oral transmission of this. Preferably the contact with the doctor, the pediatric team, and the adult team within one visit with the patient. This way it can be discussed more leisurely, betterly, and this is also reassuring. Of course, although we are in the digital time, we do have to have, apart from this oral communications, you must have the paperwork done and the summaries entered to the adult team as well. The first visit, when you schedule it, it should never be when the patient is in exacerbation. The timing should be agreed upon both centers, both teams, and the family as well. And it should be separate from any other stressful event. For example, if the patient is changing school or going to the faculty at that time, it should be not done at the same time. And it is good for the first 1 or 2 visits to continue the previous medications and treatment plans, because actually if you have coordinated your program, then it will be more or less the same, and it is reassuring for the patient that they see that nothing has really changed as you transfer to the adults. If appointment is missed, then please, you have to engage both the pediatric and the adult team to get this patient back, to make them be adherent as much as possible. And of course, we do give them ongoing support. So with the transfer itself, the transition process, as I said earlier, is not finished. Summarize. You have to have a plan, and you have to be aware that you need preparation for the adult team, for the pediatric team, and mainly for the patient themselves. You should have this good coordination of the services, and most important it is that you have a respectful relationship between the pediatric team and the adult team, that they work as a team, and that on this they will of course be able to evaluate themselves and make any progress. We all benefit if the transition is okay. Of course the healthcare system benefits, but mostly the patient do benefit from that. They are adherent, they feel better, their life conditions and the way they feel, the way they are feeling well is much better. Actually, they will learn better how to balance their chronic condition with leading a full life. And that is our goal for a good and lifelong existence of our patients. So, nothing without the team, and this is our team, both the pediatric and the adult team. And thanks to every member of this team, the transition is really rather successful in our circumstances, and I thank them all and you as well. Thank you.
Thank you, Professor Tjesic. Now I'm introducing Dr. Marlena Cohen with very interesting lecture about pregnancy, fertility, breastfeeding, very interesting.
Okay, thank you very much. And again, I want to thank all the organizers for inviting me, especially Dr. Pavel and Katerina. And I will speak today, I think it's one of the most optimistic talks in terms of cystic fibrosis. I will speak about fertility, pregnancy, and breastfeeding in women with CF. So we know that there are some issues about fertility, not only in men, but also in women. And the causes are multifactorial. And we will concentrate our talk today about fertility and pregnancy in women with CF. So the first report of reduced fertility in women with CF was 50 years ago. They reported thick cervical mucus due to low water content. Later on, in 1980s, 86 women with CF successfully treated with intrauterine insemination. The causes are multifactorial: nutritional, chronic inflammation, the mucus which is altered, and uterine bicarbonate secretion is altered. There is a theory of anovulation, probably due to insulin deficiency. The expression of CFTR is in multiple female reproductive tissues, as well as in the hypothalamic pituitary gonadal axis. And one of the theories that can explain infertility in women was decreased ovarian reserve, but limited data is available to support this theory. So this was one of our questions in our center, and we decided to recollect reproductive age women with CF that are followed by us in our CF center in Hadassah in Jerusalem. And blood was drawn for anti-Mullerian hormone, AMH, and for routine CF blood tests. A transvaginal ultrasound was performed by a senior gynecologist in a non-virgin, non-pregnant subjects to ascertain the AFC. And demographical and clinical parameters were evaluated, as well as gynecological and obstetric data. We recollected 23 women with CF. The median age was 27, and 14 of all these women expressed a desire to have children. Subfertility was found in 1/3 of the women who performed workup. 3 of the 5 have conceived and given birth to at least 1 child. And 1 from all the total of women, 1 had abnormal levels of AMH. We found no correlations between CF disease severity, serum inflammatory parameters, AMH values, or the use of CFTR modulators in our population. Overall, women with CF in our cohort had born 33 children from this cohort, with a range of 1 to 5 children per woman. So the results do not support the hypothesis that decreased ovarian reserve plays a major role in subfertility or infertility in women with CF. What about fertility? What is the prevalence of fertility in women with CF? This is a multi-center, multinational retrospective study that was done in 11 CF centers in Israel, France, Spain, Italy, and the UK. And we recollected demographic and clinical data from patients' files, genetic, status, pancreatic status, CFRD, and other clinical parameters. 621 women were screened, and 505 included in the study. 241 for this cohort attempt conception, and we found finally that the prevalence of subfertility among women with CF was 1/3, 35%, higher than the expected in the general population, which is between 5 to 15%. Older age and pancreatic insufficiency are associated with subfertility, and a trend was found in women with a pseudomonas colonization in sputum. Other parameters like sputum, like FEV1, BMI, CFRD, severe mutations, and number of pulmonary exacerbations were not associated with subfertility. What about pregnancies in CF? The first pregnancy in women with CF was reported in 1960. The woman labored prematurely, but she did not survive. The number of pregnancies in women with CF has been rising during the last decades, especially the last decade. In general, we can say that successful outcomes and without long-term implications are found in maternal health or survival. There are a lot of physiological changes during pregnancy, not only in women with CF, but in general. However, in women with CF, what are the risks during pregnancy and delivery, and what about long-term outcome in maternal and the fetus? This is a report from the ATS many years ago, and in this paper, they compared women with CF who had reported a pregnancy to those who had not reported pregnancy. And you can see here that is statistically significant in women who were pregnant in terms of number of IV-treated exacerbations, the total number of clinic visits, and the number of sick clinical visits between the two cohorts. Also, no significant deterioration in terms of lung function or BMI were found during the years after pregnancy. We tried in our center to define if there is a difference between women with CF with mild disease and with moderate to severe disease. That's the aim of this study. And we collected data on pregnancies and deliveries from 10 CF centers around the world, 6 in Israel, 1 in Barcelona, Milan, Chile, and in the US. The data that was included was severity of disease, FEV1, BMI, CFRD, chronic pseudomonas, and so on. And we recollected data about complications of the mother, the fetus, or the newborn. All the data was analyzed before, during, and up to 1 year post-delivery. We divided the pregnancies in terms of CF disease severity regarding lung function and BMI, and we compared the two groups in separate. This is the demographic data. You can see that women with the pancreatic insufficiency were in the majority with mild disease. And you can see the difference in terms of BMI. Of course, mild disease with higher values of BMI and higher values of lung function, as you can see here. What about the outcomes? So you can see here in blue, the mild disease, the mild patients, compared to in green, moderate to severe. And you can see here that were more complications before pregnancy in mild disease. Less complications during pregnancy, less preterm babies, and less complications of the newborn. However, the numbers were very, very small. So the results in this study, we showed that baseline disease severity, pseudomonas infection, and pancreatic insufficiency have an adverse impact on infant outcomes. However, it doesn't impact significantly on disease progression during and after pregnancy in women. In general, outcomes appear to be successful and without long-term implications on maternal health or survival. After that, we decided not just to analyze pregnancies, but you know that in Israel it's very frequent women want more and more children. So we recollect data and we made these multinational, multi-center retrospective studies. Data was collected on 246 pregnancies from 18 CF centers in Israel, Europe, the US, and South America. 141 women with CF had been pregnant between these years. 29% had 3 or more pregnancies, and overall, we recollected 24% of these pregnancies. 69 pregnancies in total were multigravid pregnancies. You can see here the results. We saw a greater decline in FEV1 following pregnancies in multiparous women with CF, mainly in women with CF with 2 severe CFTR mutations and pancreatic insufficiency, a trend but not significant effect on the rate of pulmonary exacerbations or disease-related complications, and higher rates of prematurity, you can see here. Prematurity and newborn complications was found in multiparous women above the age of 30 years old. These are some of our patients from my center. Of course, I have the permission. All of them with more than 3 children, 5 children in this family, 6 children, 7 children, and more. All are women with CF. So this is a paper that was recently published, and they analyzed the impact of pregnancy on mortality and lung function in patients with cystic fibrosis. This is a retrospective study, and they matched parallel cohort study. The data was collected from the American CFF patient registry between 1999 and 2018, and 1,700 women with CF that reported pregnancy were compared with the matched never pregnant women with CF. The primary endpoint for this study was the probability of survival. The secondary endpoint was the lung function over time, and the mean age of this cohort was about 25 years old. So what they found, there is no significant difference in survival probabilities between pregnant and never pregnant women with CF, as you can see in the graph. Pregnancy was associated with a reduced hazard of death compared to never pregnant with CF, and no significant association between pregnancy and lung function over time. So pregnancy should not be generally discouraged in women with CF, and risk and benefits should be evaluated on an individualized basis. So we know that as the number of adult CF patients is projected to continue to increase over the next 20 years, you can see here from the registry that there are more and more pregnancies, especially after the introduction of the ETI modulators. But what is the impact of CFTR modulators both in pregnant women and in the fetus and during lactation? So fertility may improve in women with CF who are taking CFTR modulators. This is a very important point to discuss with our and your patients. And we know that most drugs used to treat CF are considered safe in pregnancy and lactation, including the limited data regarding safety on CFTR modulators during conception, pregnancy, and lactations. This is a report from Jain that was published in Chest last year, and they recollected data on pregnancies from 2010 to 2021. From 11 US adult CF centers, 300 pregnancies. The mean age at conception was 28 years old. 37% of this cohort had a CFTR modulator exposure during pregnancy. And the results showed that the mean change in percent predicted FEV1 pre-pregnancy to during pregnancy was minus 2.3 in the unexposed group and plus 2.6 in the CFTR modulator group, with no significant change from during pregnancy to 1 year later on. Pulmonary exacerbations decreased from pre-pregnancy to post-pregnancy in the treated group, and BMI increased from pre-pregnancy to during pregnancy in all the groups, with no significant change post-pregnancy. So what about modulators in special populations? Again, this is part 1 in pregnancy and lactation, and it was published in Pediatric Pulmonology 2 years ago. And the conclusion said that minimal risk to pregnant women with CF and breastfed infant with continuous CFTR modulator treatment. Discontinued CFTR modulators therapy may pose more risk to the pregnant women with CF, as observed in case reports describing need to reinitiate therapy. Women that stopped the treatment during pregnancy and they deteriorate, we have experience in our center, so they decided to reinitiate the treatment. For developing fetus with ultrasound findings suggestive of CF, or if CF is confirmed during pregnancy, CFTR modulators therapy exposure may help treat CF-related complications during pregnancy and even delay additional complications in the baby that typically occur postpartum, like meconium ileus. So a task force statement of experts in Europe, Australia, and New Zealand summarizes that all CFTR modulators are probably safe during breastfeeding as well as preconception and all 3 trimesters. However, it's important to recognize that ivacaftor administration at all dose levels did demonstrate the development of cataract in animal reproductive models. So it's important to follow up ophthalmological examinations, and not only ophthalmological examinations, but liver function in all newborn that the mother was treated during pregnancy with the modulators. Because we know from this paper that was published in the JCF 3 years ago that there is a drug exposure to infants born to mothers taking ETI during pregnancy. They found relatively high levels of ETI in cord blood. It is suggesting that there is a placental transfer, and low levels of ETI in breast milk and in infant blood. So this is important to remember. In this paper, 4 years ago, they analyzed 45 ETI-exposed pregnancies that were reported. They found complications in few mothers. 2 of the 45 women with CF terminated unplanned pregnancies, a very low percentage of the pregnancies. Miscarriage rates were consistent with that known in the general US population. They found that 5 out of 6 women with CF who discontinued ETI out of concern for unknown fetal risk restarted the treatment because of clinical deterioration, and no infant cataracts were reported through only 2 infants were formally evaluated. So what are the key points in pregnancies with CF? Improvements in CF care and survival have resulted in an increase in the number of women with CF that are considering parenthood. In general, successful outcomes and without long-term implications on the mothers and on the fetus. CFTR modulator use through pregnancy and lactation has generally been well tolerated, but requires further studies, long-term studies, and ophthalmological and liver function test follow-up for the neonate is crucial. Close follow-up for the pregnant women, of course, by a multidisciplinary team is mandatory. Thank you very much. Any questions? Yes, Pavel.
Good morning, Malena. Thank you very much for your beautiful presentation and opening very important topic. I have 2 questions related to your practice. So you showed us to discourage from discontinuation of the ETI during the pregnancy. So is this your practice that all your pregnant women are staying on the ETI, or on individual basis you can allow to discontinue at least for the first trimester because of the risk factor during the embryogenesis? And the second question, who cares for the neonates and the children of mothers in your CF center? Is it the adult pulmonologist? Probably not. Pediatric team, or is it up to the GP with some recommendations that ophthalmologic examinations and liver function tests should be done on a regular basis? So what is the practice of your CF center?
Okay, thank you for the questions. I will start with the first question. The first question, I think we try to do more personalized medicine and to choose the patients that they are in a very good condition and they ask us that they are planning pregnancy. So I prefer to stop the modulators and to try if everything is okay, but we ask them to be in follow-up with a very good frequency. They are coming at least once in a month or more than that. So some of the patients could discontinue it at least during the first trimester. In the other extreme are patients with a severe condition or more moderate to severe disease, so I prefer to continue, but I have to tell them that there are no long-term data, so I'm not sure that everything is safe. So they have to decide if they want to continue or not. I remember 2 patients that discontinued the CFTR modulators, and later, after a few days, they started to feel no good with the exacerbation, so they tried again. We have actually about 40 or more than that children that were born from pregnant women that were on modulators. Everything is okay till now. And regarding your second question, so when they deliver the baby, so we ask them to do ophthalmological examination during the first month and liver function tests after birth. I remember 3 babies that were with abnormal liver function test during the first days, and then they repeated it, and everything was okay. The follow-up, they continue to do it with the pediatricians, but I follow them, I call the pediatrician and I check if everything is okay. Till now, all the babies are okay, but I'm not sure what happens regarding the developmental with the children in the long term. I'm not sure. So it's important to continue to follow the babies, the children. Yes. Thank you. Okay.
We would like to use a short minute to give you, all the speakers, as a thank you, some small token as a memory for your contribution and taking your time to come here and share everything you have with us and with the audience. So thank you all. So can you stand up so we can make a joint picture and then...
Bienvenue.
That minuta pauză coffee.
10 minutes.
Well, welcome back everybody to this next session. You can bring your coffees to your chairs, that's no problem. But in the interest of time, I think we'll make a start. So we'd like to introduce our first speaker to this next session, Dr. Federico from Rome, who's going to be kindly talking to us regarding gastrointestinal manifestations, pre and post modulators. So thank you so much for coming and for being part of this, and we'll pass over to you. Thank you.
Good morning to everyone. Thank you to the organizer for inviting me to this nice conference. I am an adult gastroenterologist. I work at the Bambino Gesù Children's Hospital in Rome. And also for this reason, my first role during this presentation is to point your attention on extrapulmonary manifestation of CF. And as you know, the CFTR protein is highly expressed in the gut, in the pancreas, especially in the apical surface of duct cells in the pancreas, and also in the cholangiocytes. And a CFTR defect may impact negatively on the onset of gastrointestinal manifestation and also pancreatic disease and hepatic liver disease. During my presentation, I will show you the most relevant GI manifestation. I want to point out your attention on the pathogenesis of gastrointestinal manifestation that are very complex, multifactorial, and related also to the presence of dysmotility. Dysmotility is present along the gut and may be related to a direct consequence of a CFTR defect causing an alteration of the smooth muscle function and also the enteral nervous system, and probably is also a sequela. The dysmotility is also a sequela of several factors, several important elements that occur in CF patients, mostly pancreatic insufficiency, also the fat malabsorption, also the presence of bacterial overgrowth and dysbiosis that are related to intestinal inflammation. As we many times measured through the measurement of fecal calprotectin, and also to dysregulation of gut hormones. So there are various complex multifactorial aspects that predispose to CFTR-related GI manifestation. And focusing on the main, most relevant gastrointestinal aspect in CF, I start with the upper gastrointestinal tract, so I had to mention the gastroesophageal reflux disease, that there is, this is a common disease in general population and also in CF population. It is a disease common also in children, not only in adults. And the pathophysiology of GERD is partly common to non-CF patients, involving transient lower esophageal sphincter relaxation. And also there are several aspects more specific for CF patients that predispose to GERD. They are a delayed gastric emptying and a low gastric pH related to a decrease in bicarbonate secretion, and also chronic cough and chest physiotherapy may impact on a more relevant pressure, abdominal pressure that favor the episodes of reflux. From a clinical point of view, in CF patients, there is a high prevalence of extraesophageal symptoms. But I also underline that 1/3 of patients may present GERD in a clinical silent mode. Most of the gastroesophageal reflux events are proximal, reach the proximal esophagus and are mainly acid. And a combination of higher cough frequency and poorer lung function are associated with a major risk of microinhalation, aspiration. And vagal-mediated esophageal bronchoreflex may also contribute to the onset of symptoms, the onset of GERD, and also on the lung function deterioration that is obviously important in CF patients. There are no CF-specific guidelines for GERD, so we refer to general GERD guidelines. It is relatively easy to manage and treat classical typical symptoms of GERD like airbur or regurgitation. In this case, it is indicated to start a treatment with proton-pump inhibitors and then successively modulate this therapy based on the clinical presentation during the time of patient. In other cases, more complicated or more difficult to diagnose, it is necessary to perform, for example, upper endoscopy. That is a procedure indicated in case of alarm symptoms, like, for example, hematemesis or like dysphagia, or in case of no response to PPI, to exclude the possible other etiologies like eosinophilic esophagitis, or also in prolonged PPI use without any possibility to stop the therapy, to exclude possible complication like, for example, the Barrett esophagus. And the 24-hour esophageal pH impedance monitoring also is indicated in presence of atypical symptoms, mainly respiratory symptoms, and in case of no response to PPI with an upper endoscopy completely negative. It is important also to manage properly the PPI because sometimes there is no clinical response because it is not appropriate the use of PPI for duration or for the correct administration or for the appropriate dosage. And it is also important to consider that prolonged use of PPI may favor the onset of infection and pneumonia. So this aspect is important in people who suffer of respiratory symptoms. The surgery is also indicated in some cases when we have patients with persistent nutritional decline or frequently pulmonary exacerbation or decline in pulmonary function. This is maybe the first indication for the surgery. We can recur to the surgeries also for inadequate symptom control and also for complications like Barrett esophagus, and also before the patients undergo lung transplantation. The meconium ileus, going down to the small bowel, the meconium ileus is maybe sometimes the first manifestation of cystic fibrosis. In the graph on the right, you can see the prevalence of meconium ileus in the European countries, taken from the European CF registry, and with a mean prevalence of about 15% of patients suffering of this manifestation. That is mainly related to the presence of pancreatic insufficiency. The meconium ileus is characterized by a failure to pass meconium, abdominal distension, and bilious vomiting. and nearly half of babies may have complicated meconium with atresia or volvulus or perforation that require surgery. In normal cases, we tried firstly to have a conservative therapeutic approach that consisted in intravenous rehydration or enemas with hypertonic solution like gastrografin that may be useful or may be useful also for therapeutic. But surgery is obviously necessary in case of complication and also when the medical treatment is not effective. Another similar manifestation in the gastrointestinal gut to the ileus meconius ileus at the distal intestinal obstruction syndrome, very typical for CF patients. Same pathogenesis, but it occurs in older children and adults. There is the DIOS, distal intestinal obstructive syndrome, is frequent both in children and adults, but not so frequent like previously reported in literature. This is probably due to the fact that in the past DIOS was confused with constipation. That is another frequent manifestation in gastrointestinal frequent manifestation in CF patients. But constipation have different characteristics because constipation usually is a chronic disorder that feature a reduce of frequency of evacuation. The DIOS has other characteristics as and subacute or acute onset, characterized in the complete form by intestinal signs of intestinal obstruction, quindi biliary vomit or fluid levels in the abdominal radiography, fecal mass in the ileocecum, and also abdominal pain and distension. There are several factors predisposing to the DIOS, especially the presence of meconium ileus, the pancreatic insufficiency, and previous history of other episodes of DIOS in the past. Complete form of DIOS is associated with longer hospitalization and a higher percentage of failure of medical treatment. And children with a previous history of meconium ileus has a higher rate of surgery. Also, other factors that contribute to a prolonged hospitalization are a delayed arrival in the hospital and prior weight loss of this patient. So these underline the fact that this complication should be recognized timely and treated properly as soon as possible. The treatment of DIOS, the incomplete form of DIOS or not severe complete DIOS, can be managed by oral rehydration and osmotic laxatives like the polyethylene glycol at a maximal dose of 2 grams per kilo day. The severe forms needs hospitalization, intravenous rehydration, nasogastric aspiration, and also enemas or local instillation when it is possible with the gastrografin. And surgery is seldom required, and we have to try to avoid that because of high comorbidity and possible risk of mortality for this patient. And after the resolution of DIOS episodes, it is suggested to start also a prophylactic therapy with oral absorption of polyethylene glycol. Other gastrointestinal manifestation is the exocrine pancreatic insufficiency. As you know, the pancreas is the most sensitive organ to the CFTR dysfunction because we observe damage of the organ just in utero, and this translates into an 85% of patients that are just pancreatic insufficient at birth. The EPI is associated with severe genotype, quindi severe class 1 to 3 genotype mutation, but 2-3% of these patients are pancreatic insufficient at diagnosis and develop later the pancreas insufficiency. This is an important aspect when we will talk about a possible role of modulators on this manifestation. The classic clinical manifestation of pancreatic insufficiency is steatorrhea, weight loss, and failure to thrive. And as you know, there are guidelines well done to manage also the pancreatic, both the pancreatic insufficiency and also the supplementation with fat-soluble vitamins. And there is a role, there is a manifestation also for the pancreatitis in CF patients. As you know, the CFTR is important also for the bicarbonate secretion in the pancreas. That is a key aspect for the onset of pancreatitis. Pancreatitis is associated with a residual pancreatic function due to the presence of mutation, milder mutation in the class 4-5 of CFTR. From a therapeutic point of view, nothing is different from the management of other acute pancreatitis because the main aspects to treat these patients is basically based on the hyperhydration, pain control, and early refeeding as soon as possible. And this is the three main aspects important for all kinds of acute pancreatitis, independently of the etiology. And what do we know and what do we expect from the CFTR modulators on the gastrointestinal symptoms? We expect a lot. Probably we don't know so much so far, but there are several reports indicating that an early treatment of patients with CFTR modulators may be helpful to recover pancreatic function, as demonstrated in these studies, the Arrival study, the Kiwi study with the ivacaftor, and later another study in infants treated with ETI, in which we observed a percentage of patients who recover the pancreatic function measured by the determination of fecal elastase. And this value remain constantly normal along the entire study. Another important aspect for the early treatment, for the possible early treatment, is on the meconium ileus, because there are several reports in the literature, maybe about 10 cases reported, of fetus treated in utero by administering ETI to the mothers. And some of these patients resolved the meconium ileus in utero, and in one case, maybe the first present in the literature, a CF mother had a child with homozygous for delta F mutation that had at birth a negative screening for cystic fibrosis and a normal pancreatic function. So this is an important aspect in the future for a possible early treatment for patient for GI complication. And what about the pancreas? ETI probably improved the pancreatic function. This may be on one hand that patient with pancreatic insufficiency that normally don't have a risk of pancreatitis may gain a pancreatic function that increase their risk to develop pancreatitis. On the other hand, patient with pancreatic insufficiency may improve their function that go beyond the risk window. So this enhance their pancreatic output without any further risk of pancreatitis. But there are no great literature about this topic, so future research is needed, but surely it is an interesting aspect in GI manifestations. And what about other GI manifestations? There are several reports in literature of a benefit of ETI on transit time of the bowel, on the GI symptoms measured by different questionnaires, but we don't have also in this case sufficient data to demonstrate an efficacy of the CFTR modulator on these aspects. Maybe it could be related on the fact that GI manifestation, as I said at the start of the presentation, are very complex. And maybe ETI or other modulators needs more time to be completely efficacious. In other cases, maybe the presence of other aspects other than the CFTR defects may contribute to the persistence of GI symptoms. I mean, for example, adherence to therapy, change in the diet of the patients, adherence also with the treatment with the ETI. So there are a complex scenario that needed further investigation in the future. And with the increasing longevity, with increasing longevity of the patients, there are increasing manifestation comorbidities that require our attention. One of them is the possible onset of malignancies that are especially important in the GI tract, especially for the colorectal, but also outside the gut. And this is an aspect to monitor in the future. It is probably related to the fact that CFTR gene play different roles also on the tumor biology, including not only the ion transport, but also the epithelial mesenchymal transmigration, important for the onset, for example, of metastasis, and also on the cellular proliferation or drug response to chemotherapies. So it is important to consider also this aspect in the future management of this patient. And guidelines are available for the screening of colorectal cancer in patients transplanted and not transplanted. The transplanted patients may have an early surveillance starting from the 30 years of age, and the other patients starting from the 40-year age. And it will be interesting to see in the future, through observational studies, the effect of modulators on the, on the epidemiology of malignancies. Other aspects to consider is other important comorbidities, like the CFTR diabetes. As you know, diabetes is the most frequent complication of CF patients. There are complex pathogenesis of the disease related to the pancreas and the insufficient insulin availability, but also to insulin resistance and inflammation. And for this reason, this complication may need to be monitored since the first decade of age through the oral glucose tolerance test, and managed when the diabetes is present with the help of the endocrinologist, diabetologist, to start properly treatment with insulin. And in the future, the continuous glucose monitoring could be a technology helpful to establishing a consensus guidelines around the CF-specific glycemic targets to identify patients at major risk to develop diabetes, in which it is possible maybe to start an early treatment with insulin. And about CFTR modulator for these patients, we can say there are no sufficient data to be conclusive. The data available show that ETI improves average glucose or glycemic variability and the time in target range measured by CGM, but it is not sufficient to be conclusive and needed further evaluation in the future. And another also comorbidity that require our attention is the CF bone disease, especially considering that these patients at either higher risk of fracture, especially vertebral fractures that may affect negatively the patients, considering the risk of reduced physical activity or the possibility to perform chest physiotherapy. There are no data about the use of CFTR modulator on the CF bone disease, but it is possible to think on that ATI may be helpful to improve this aspect, because if you see the risk factors for the disease, most of them are elements on which the modulators can act successfully, like not only the CFTR dysfunction, but also malnutrition or exacerbation, or, for example, the use of glucosteroids that in patients taking CFTR modulators are less frequent. So this my presentation is highlight the need for shift our management of CF population, because CF population is changing, more longevity, more possibility to treat with CFTR modulators, and so many aspects need in the future to be strictly monitored. For example, the treatment, if possible, early treatment of pancreatic insufficiency, but also, as I say, the CFTR, the diabetes, and the bone disease. So, in conclusion, I can say that improvements in treatment for CFTR-related lung disease with associated increase in longevity have, as I show you, increased the prevalence of the extrapulmonary manifestation. The CFTR gene dysfunction in the gut is already present in utero, affect the patients in their whole lifespan, causing major comorbidities and negatively influencing the quality of life. And CFTR modulators appear to have a positive effect on GI disease, especially if started early. GI symptoms improve, but not completely resolve, probably due to the complex multifactorial pathogenesis of the disorder. And CF goals, our goals must be set on increasing people with CF longevity and comorbidities. So longitudinal large course studies are needed to a better management of CF extrapulmonary disease. So thank you for your attention.
That's wonderful. Thank you so much. It was a very comprehensive and excellent presentation. Thank you so much. I think in the interest of time, we'll move on to the next speaker, but if anyone has any questions, please do come and speak to us after.
Excuse me. Let's continue with the other speaker. I invite Dr. Shurata Efendia Becha nga Kosova të prezantoj punimin e saj, prezantimin e saj për smundjen e lidhur me fibrozën cistike. Let's go to the other presentation with Dr.
Thank you. Dear participants, my presentation today will be with regard to extrapulmonary diseases of the cystic fibrosis, as is the liver disease, which is a significant disease with serious complications, endangering the lives of the cystic fibrosis children. It is related with pathogenes. Early diagnostication is helpful in order to manage them properly. Something about cystic fibrosis. It is a fibrosis transmembrane conductance regulator. This disease is actually related with the CFTR gene, which has a defect on chloride channel expressed in epithelial cells. This disease, or CF-related liver disease, does not attack all CF patients. Only 30 to 40% of them may manifest liver diseases, out of which 5 to 10% of them are manifested with advanced changes that actually endangers the CF patient lives. This cystic fibrosis related to liver disease, related to the CFTR defect, includes two main and sometimes coexisting manifestations: focal biliary fibrosis and portosinusoidal disease. With regard to the European criteria on definition of the CFLD, are presented at least two of the three criteria required to meet: abnormal physical examination, abnormal liver test, and abnormal liver ultrasound suggesting fibrosis or cirrhosis, which actually follow with the homogeneity of the liver. Two of these factors actually are important, are very important indeed, and they also present the incidence of the disease, where the children of age up to 18 were followed, with the incidence of 1.8% in patients with CF. As patient management has improved, and with the increase in life expectancy of patients with CF, studies have shown that there we have cases with adults. In order to understand the mechanism of the cause of this disease, we should also know the pathophysiology of the disease, as the CF is caused by, mutations in the CFTR gene, which actually leads to thickened mucus. In this case, this thick mucus clogs bile ducts. They actually cause inflammation. We have shown it in the image here. So it comes to over time. This leads to the biliary cirrhosis and clogs bile ducts and so forth, which actually cause burdens, increase biliary acid, and damage the liver. So the important factor that actually leads to focal changes is actually the thickening of biliary cirrhosis. And actually it damages the liver, and it sends to the irreversible damages of the liver. There are many main hypotheses of the disease, and they are the biliary fibrosis, which we spoke about it as shown in the image. It's inflammatory processes which actually self-activate the tyrosine kinases, which leads to inflammatory processes via the phosphorylation of the toll-like receptors for activation of NF-κB and the production of pro-inflammatory cytokines. Gut dysbiosis, which is responsible for gastrointestinal diseases, but also responsible for the well-being of the body in general. If it is dysregulated, then it also dysregulates the innate immunity. It has also impact of the natural immunity. And the last one is platelet activation, which are creation of microthrombic, which damages the endothelial issues. The liver disease is manifested with three phenotypic characteristics. The first one is when the community, CF community, does not attack the liver, is no liver involvement. The second one is with the liver involvement, with or without portal hypertension, but without cirrhosis. And the third one is multipolar cirrhosis with or without portal hypertension or liver failure. So these are the phenotypic characteristics which we face on our daily work when we do tests. The general signs and symptoms of the liver disease are, this disease actually goes silently, sometimes it's asymptomatic, but during screening what we look for into is hepatomegaly, jaundice, ascites, and portal hypertension. And the last one is the advanced stages that may lead to cirrhosis and liver failure. Diagnosis in order to diagnose the liver disease with CF is quite silent, as I said before. It's not as easy as, we should always do research. We should also, we should do it annually. We should do annual screening of the liver to see the portal hypertension, through the screening. it is one of the key diagnostic ways in evaluating or testing the liver. We test the size and the form and the structure of the liver. Other tests that helps us also are liver function tests, abdominal ultrasound, elastography, fibroscan, and if we have liver failure, we have the liver biopsy at the end. So all these are diagnostic tests. There is a liver ultrasound scheme. The ultrasound is one of the first methods that needs to be applied in detecting liver diseases. When we are dealing with CF patients, based on the scheme, we see that through the ultrasound, we may assess the form, size, and see whether we are dealing with the hepatology, or if we are dealing with the structural changes of the liver, whether the liver is homogeneous, has it been attacked. If we see modular changes in the ultrasound, then we mark it with the red flag, as a red flag, which actually suggests us that we continue to require the elastography. It is another way of diagnostification, which talks about the elasticity of the liver and the changes that actually lead into hardening of the liver. It is one of the ways actually that quite early detects damage of the liver if we have no other ways to do the diagnostification. What we should bear in mind is to assess the portal hypertension. So if we find a portal hypertension, then it is necessary to also assess its complications, which should be done through the endoscopic methods of the above digestive ways. So this is an algorithm that actually needs to be looked for a portal hypertension. It is a schematic way or images of the ultrasound. Thank you. It is an image actually where in picture A we have a normal liver. Picture B represents the changes of the homogeneous hyperchogenicity. In C we have heterogeneous hyperchogenicity. And in picture D we have nodular changes, which I said are pathognomonic for the liver disease, which shows that there is a liver disease happening there, which is a kind of a criteria to move on with the second methods of diagnostification, which is elastography. It is one of the ways which is based on the elasticity of the liver, which is found to be valuable to find early stage diagnosis. This actually, it is one of the most sensitive methods helping us in finding the disease. There are some modalities, transitional elastography, ultrasound guided elastography, and point shear wave elastography, which can be done in two-dimensional shear wave and as well as magnetic resonance elastography. We have images here, schematic images of the elastography, which are actually competent for early detection of the liver disease. What are the complications and of the liver? Why do we do this annual screening of the liver disease? Is that the complication that might lead to liver failure and may damage the health of the CF patient. One of them is portal hypertension, which is characterized It is one of the most often complications happening with biliary cirrhosis or secondary to sinusoidal vascular diseases. These should be carefully assessed because it may develop in the absence of cirrhosis. It is important to follow them as esophageal varices, cirrhosis, and hepatic encephalopathy. So prognosis depends on early detections and management. Liver transplantation improves survival in advanced cases. It is also important that if we detect them at an early stage, we may save lives of these people. In a differential diagnosis, we should differentiate the disease which is related to the CF gene. Other hepatic factors come into the surface. These patients actually, we have the iatrogenic damage of the liver. Many medicaments are taken. They have hepatic congestion, you know. So we quite often find changes of the liver which are not related to the CF gene. Other factors are also hepatic congestion because of the heart failure, which comes due to the advanced lung damage as a retrograde etiology, and bacterial viral infections of the liver, which are not related to the CF. The importance why I put it as a differential diagnosis is that because if we do not relate it with the CFTR, then the therapy should change as well, and we may not, account on the actual therapy. Management and treatment of the illness. We know that there is no adequate cure for the cystic fibrosis. But the important is to slow down the disease process, we slow down the progress of the illness. So the treatment strategy is by using ursofag to improve bile flow, nutritional support, and different supplementation. And as the last one is mentioned, is the liver transplantation, for which actually is worth using when the liver fails entirely. But it is important to note as well that we should continue to apply regular screening, which actually is key for early detection of the liver disease. The new therapy has many development modulators, which are CFTR modulator therapies, inhibition of skin tyrosine kinases and mediated inflammatory process, and FGF19 and its analogs, which are, at advanced research forms, which are quite promising for treatment in the future. And the vitamin D plays its role in regulating dysbiosis of guts, which helps us in maintaining normal guts when it, dysfunction. With regard to the CFTR modulators, there are some actions or 3 ways of these modulators, and based on these actions we will do the selections that which modulator is applied later on. The first factor is correcting the CFTR misprocessing. The second factor increases the absorbing surface of the protein, and the third one it keeps opening of the protein channels. Based on these modulators or these ways of doing work is we choose the gene modulator. There are some types of modulatory therapies in the market. I've pointed out 5, but I've highlighted 3 of them. Trikafta is a combined preparat which covers 3 types of the gene, of the defects. It is quite an advanced medicament. Arkambe is also a combined medicament, which role is mainly on mutations related to F508 gene defect, which we find quite often in our cystic fibrosis children. That's why I consider it to be, quite useful to provide in our country. And the last, an EVA factor, which actually is applied to children from 1 month. It can be prescribed to children from 1 month, so that the children can have, a longer life, longevity in life. The side effect of a factor may have changes in sights, in eyes, as they might have the cataract development, but of course that we should monitor them continuously for the complication of that might happen to them. As a conclusion, I might say that the CFLD actually is a significant complication and often, puts the patient's life in danger, but it is important to detect them at an early stage so that the management can be, a better one. It is important to follow up and monitor annually by doing the liver tests, ultrasound, and the treatment be in a proper way in order that the disease does not progress. It is quite important as well that monitoring these illnesses or diseases be done in teamworks, because it's rather difficult the cystic fibrosis patient be followed these complications outside of the lungs, as in gastrointestinal, should also other organs be followed. So only teamwork will make the dreams come true in order to have a better life for the children. Thank you very much. Thank you very much, Dr. Orata. If the auditorium has questions, please place the microphone.
Sepse jemi edhe keq me kohën realisht.
Jem me qito. Thank you, Doctor, for your presentation. Let me just introduce myself. I am Professor Poloska, regular professor at the university. I have a question for Dr. Orata. We know her work, her success as well. I have a question in this regard. Based on which algorithm that you pointed out is the liver biopsies, the ultrasound, in identifying the involvement of the liver in cystic fibrosis? What are the patients, what are the number of patients that you have identified, your excellent job that you're doing in the clinic? Thank you, Professor. The diagnostic algorithm is based on the data and the criteria set out by the European Association for Gastroenterology and American Association. They actually assess and they say that an annual screening should take place, should be done, which includes the ultrasound as the first diagnostication method. If we have changes in the ultrasound, nodular changes that change the structure of the liver, the elastography comes the second. Fibroscan, and as a biopsy, only if you have changes of the vascular portosinusal, which actually brings a hypertension, portal hypertension. So there might come, other complication in this due to this happening. In these cases are not as often, one third of cystic fibrosis related liver disease, but we have no elastography in Kosovo. We don't do fibroscanning. That's why we are, need to find, help in the region for elastography and bioscanning. It is a diagnostification way that comes into questions on special cases and in complications when there needs to be decided whether liver transplantation should be taking place or not, which actually improves the quality and also brings a better life and longer life to the patient. Thank you. Thank you very much. Then we move on forward as we are behind the schedule. Thank you, doctor. Now let me represent you, Ms. Shqipe Spahio from the Republic of Kosovo, newborn screening subject. Yes, Shqipe?
Dear colleagues, my presentation today is newborn screening in Kosovo plan and program. So we worked on the program for the neonatal screening in Kosovo. I've been in the working group. The program has been approved by the Ministry of Health, and we are at the last steps to start the screening. So this will be this year, means we'll start with the neonatal screening in Kosovo. Drafting of neonatal screening was a priority of the Ministry of Health based on the strategy for the mother's health and also for the reproductive health. The action plan, strategy action plan was 2023-2025. We have also proposed to make the neonatal screening with a purpose that diseases to be detected as early as possible, reduce morbidity and mortality, and prevent irreversible changes, starting the timely treatment of these diseases. The working group on drafting neonatal screening program analyzed and based on a lot of plans and programs of different countries, considering their experiences, but of course adapting to the conditions of our country. The newborn screening program is comprised of two parts. Narrative part describing what the screening is, why there are advantages to make neonatal screening, which diseases are detected in different countries, which are the benefits and advantages of neonatal screening, means all what it is about neonatal screening of the diseases screened. And the second part, which is more important, it is an action plan describing the activities which should be undertaken for the implementation of neonatal screening timelines. For the implementing of these activities, the cost of implementing the neonatal screening, specific roles, as well as supporting roles of all stakeholders involved in this program, as well as expected results. The plan means clearly defines the activities which should be undertaken for the realization of the screening, as well as coordination of all stakeholders who have key roles and supportive roles. The timeline of implementation of these activities is 2024-2025. Now we are in 2025, and we do expect very soon to start. By the end of 2025, specific objectives of the program are we have to make the design and implementation of standards for the realization of the screening, provision of infrastructure and equipment for implementing the screening, provision of professional capacities, as well as awareness of population for the importance of neonatal screening. The screening will be conducted in all health levels of Kosovo, in all maternities, regional hospitals, general gynecology clinic, as well as private institutions, and it is supported by the Ministry of Health, respectively, from the Hospital University Clinical Service of Kosovo. The financial activity of this plan will be monitored and reported in a regular basis. Which are the ranges will be considered for a successful neonatal screening? Initially, we have to notify the parents why the screening is important and which diseases will be screened. Then sample blood from females 24 after giving a birth, up to 48 hours. The blood should arrive at the lab not later than 48 hours after obtaining, and the result will be forwarded back to the institutions where the sample was taken. Also, the plan includes the procedures after positive results, as well as algorithm for certain diseases. We have also made cost effectiveness analysis on screening, and we have come up to the conclusion that the society will be saved from huge costs about the treatment of irreversible changes and long-term changes of different diseases. Diseases which will be screened are galactosemia, cystic fibrosis, phenylketonuria, hypothyroidism. Also will do screening for prematurity retinopathy. This already is realized, as well as hearing screening. The leading institution is the Ministry of Health, and in order that the program and the activity goes well and be monitored properly, we have established a matrix for monitoring and reporting of the action plan for the neonatal screening. The Secretary General appointed a working group for the implementation and monitoring of the action plan in order to approve this screening. Monitoring matrix contains all the results, activities, sub-activities, as well as timelines, baseline, target data, processing of data, the current status, as well as leading institutions, support institutions, as well as the progress and comments section. Also, the reporting is periodical. It will be reported on all data, also for the eventual changes, challenges that will arise on the way. This is the Nobelisk when we have declared our independence, and already 17 years we are a state, not too many years, but our years makes us responsible that still we don't have neonatal screening. Thank you very much. Do të doja të ftoj Chris Smith nga Britania e Madhe që të bëj prezantimin e tij për nutricionin e fëmijëve dhe të rritërve me prioritetet kryesore të nutricionit. Faleminderit shumë dhe faleminderit edhe organizatorëve që më keni ftuar të flas. Dje ju fola për projektin e edukimit ICFS, që është një prej roleve primare që kam në shoqëri, por unë kam fillu karrierën time në fibrosis cystike në fushën e nutricionit, dhe nutricioni është dashuria ime e parë, pra jam shumë i lumtur që të flas për udhëzuesit dhe prioritetet e nutricionit, nutricionizmit, tri porosi kryesore për juve, dhe mesazhi i parë që e kam për juve është që ka shumë udhëzues ndërkombëtar për nutricionin lidhe me fibrozën cistike dhe duhet t'i theksoj për juve se cilat udhëzues janë të disponueshëm dhe prioritetet që këta i ballafaqojnë. Përgjegjësia e dytë që kam për juve që jo të gjithë udhëzuesit e nutricionit duhet të zhvillohen apo kanë zhvilluar për dekadën e fundit dhe duhet të theksoj për juve arsyeën që evolucioni i nutricionit ka ndryshuar dhe po ashtu të theksoj se çka ka ndëruar në për këta udhëzues. Dhe porosia e tretë që kam për juve është që në të gjithë udhëzuesit ka tema kryesore dhe prioritetet kryesore. Çka do doja të bëj është të sugjeroj juve 4 prioritete kryesore për menaxhimin e nutricionit në të gjithë pacientët me fibrozë cistike. Pra këtë 2 pika kryesore ndërlidhen me fjalën time të parë për udhëzuesit e nutricionit dhe pika e tretë lidhet me fjalën time të dytë që ka të bëjë me prioritetet e kujdesit të nutricionizmit. Pra do të filloj këtu për të folur për udhëzuesit e nutricionit që janë të disponueshëm dhe dua të bëj një gjë shumë të qartë që ka të bëjë me arsyeën pse ne kemi udhëzues ndërkombëtar të nutricionizmit dhe kjo është që nutricioni ka rëndësi. Në fakt nutricioni ka vërtet rëndësi dhe se rrëfimi të ushqyerit dhe fibrozës cistike apo nutricionit fillon 6.000 milje nga këtu dhe rreth 40 vite më përpara, për shkak se atëherë në vitet 80 ka pas krahasime mes dy gjërave që kanë pas shumë qasje të ndryshme të nutricionizmit apo të ushqyerit dhe fjalia e parë ka qenë në Toronto dhe ata kanë adresuar në këtë qendër një vrojtim të shoqëruar me fibrozë cistike me kalori të lartë, yndyra të larta që kanë kriju enzime pankreatike të mëdha dhe kjo është krahasuar me qasjen e qendrës tjetër, në qendrën në Boston ku është trajtuar dhe menaxhuar dhe për dietë për yndyrat dhe enzimat pankreatike. Po ashtu është zbuluar një krahasim mes dy qendrave në dy qasje të ndryshme të ushqyerit dhe është bërë shumë e qartë që dallimet për pritjet kanë qenë pothuajse 10 vjet dhe shumë prej kësaj është vënë në qasjen e të ushqyerit në mes të dy qendrave. Pra që nga atëherë shumë studim fundamental, 40 vite më parë, shumë studime kanë vazhduar me themelu marrëdhënien mes gjendjes pozitive të ushqyerit, rezultateve pozitive dhe fibrozës cistike. Për shembull, ne dim kemi përditësuar lidhjen me optimizimin e të ushqyerit, me cilësimet e mirë të jetës, me përkeqësime dhe hospitalizime, pastaj pra është establishmenti i rëndësisë së ushqyerit ka qenë në fokus të udhëzuesve të nutricionizmit apo të ushqyerit, sjellin monitorim, menaxhim dhe trajtim për personat me fibrozë cistike dhe kemi 4 udhëzues kryesorë ndërkombëtar për nutricionin me FC. Një prej tyre është udhëzuesi nga Amerika e Veriore në 2020-ën, CF Guideline për Amerikën Jugore, kemi një për Azinë, Australinë dhe New Zelandën, Australinë dhe së fundmi kemi publikimin për udhëzuesin evropian për të ushqyerit për fibrozën cistike publikuar në 2024. Tani dua të theksoj për juve 2 sfida të dallueshme që ballafaqohemi kur shkruajmë këta udhëzues në 2024-ën. Një prej këtyre sfidave ka të bëjë me ndryshimin e madh që shohim me disponueshmërinë, sepse kur kemi bërë hulumtime fillestare për të mbështetur udhëzuesit e të ushqyerit dhe mund t'ju tregoj se si duket, mund të shihni kur kemi hulumtuar fibrozën cistike, kemi parë pothuajse mira letrat që janë publikuar në 40 vitet e fundi për të mbështetur këto udhëzues. Kur ja shtoni këtë modulatorët dhe kur shikoni rezultatet se çfarë ka pasur, ka një numër të madh të letrave, dokumenteve që kanë rënë dhe një ngarkesë e madhe kur kemi pas hulumtim për të ushqyerit. Pra sfidat që jemi ballafaquar me shkruan një udhëzues të ri kanë qenë të dhënat historike për të ushqyerit dhe FC-n mund të mos jenë më tutje të përshtatshme dhe pastaj terapia e të ushqyerit është me furnizime të shkurtra. Me qenë se kjo është sfida e parë që ballafaqohemi, sfida tjetër ishte menaxhimi të ushqyerit po ndryshon shpejt dhe edhe pas publikimit të kësaj në 2024 brenda 6 muajve ne kemi filluar me punën e dokumentet e mëpastajme për të adresuar menaxhimin e të ushqyerit. për shkak të shpejtësisë së progresit dhe ky dokument do të përfundohet më vonë këtë vit dhe të mbuloj fushat e reja të kujdesit të ushqyerit, përfshirë menaxhimin e të ushqyerit gjatë kimioterapisë dhe enzimat pankreatike. Pra, këto janë 4 udhëzuese ndërkombëtar. Dokumentet, po janë informatat e vetme burimore, kemi 2 publikime në disa vitet e fundit nga Fondacioni FC për menaxhimtarshëm të ushqyerit dhe roli i zhvillues i të ushqyerit brenda CFT-s dhe kemi dokumentet e kujdesit, se cila prej tyre ka seksione për nutricion dhe ka rekomandime dhe udhëzues që janë absolutisht me njohuri dhe përsëri i kemi marrë memoristiket për edukimin, është përkthimi gjitha këtyre standardeve në gjuhën shqipe për të ndarë këto informata. Pra, këto janë udhëzuesit ndërkombëtar të cilët ne i kemi dhe dua të dal tani për të shpjeguar se çka ndodh gjatë dekadës së fundit sa i përket parimeve dhe menaxhimit. E di që është arsye shumë e thjeshtë përse të ushqyerit, mjekimi, menaxhimi është dashur të zhvillohet dhe kjo është për shkak se ka pas përmirësime të qëndrueshme në statusin e të ushqyerit brenda disa dekadave të fundit dhe është e vërtetë që përmirësimi i statusit të ushqyerit bën mes vendeve, mes kontinenteve, por drejtimi për përmirësim të ushqyerit është konsistent në mesin e çdo kund dhe ka shumë faktorë për të ushqyerit që kemi parë, jo shpejt për të na shkuar në për disa prej këtyre. Së pari një ekzaminim të porsalindrëve për publikimin e 2020-s ilustron origjinën e vendeve që kanë themeluar programet e ekzaminimit të porsalindrëve dhe programin që kemi filluar këtu në Kosovë dhe duke shtuar një vend tjetër kësaj. Po çka dim për ekzaminimin të porsalindrëve, studimi i 4 vendeve, statusi nga Amerika Veriore, Amerika Jugore, Australia dhe Evropa, të gjithë mbështesin marrëdhëniet e ekzaminimit të porsalindrëve, normat e larta të keq ushqyerit dhe ofru jetëgjatësi për të rriturit dhe për të fëmijët. Pra, ekzaminimi i të porsalindrëve ka status dhe kjo nuk e parandalon keq ushqyerjen dhe vendet ku ekzaminimi i të porsalindrëve është themelu, sikurse në US, SBO, kundrejt ende ndodh keq ushqyerja dhe se kjo nuk e parandalon, është thjesht duhet të zvogëlohet. Pra, ekzaminimi i të porsalindrëve duhet të përmirësojë gjendjen e ushqyerjes, po ashtu në përmirësim të ushqyerjes për trajtime të mëvonshme, pikpamje sistematike tregojnë marrëdhënien mes rritjes së shërbimeve të reja dhe përmirësimit të peshës, pastaj marrëdhënia për të identifikuar problemet kryesore dhe në fakt duhet të kthejmë inxhinierët për të kuptuar etimologjinë përmes përmirësimit të peshës, prej nga ka ardhur përmirësimi i peshës dhe kolegët kanë përmbledh dhe kanë sugjeruar zvoglimin e shpenzimeve, përmirësimin në vrojtimin intestinal dhe mbështetja e marrëdhënieve në mes të peshës dhe përmirësimit të shëndetit. Pra, për me përmirësu statusin e të ushqyerit dhe kjo për shembull është përmirësu në vlerësimin e të ushqyerit që ka kujdes në secilin prej rishikimeve që ndodh dhe po ashtu zbatimit të udhëzuesve ndërkombëtar të FC-s duke pas parasysh menaxhimin, monitorimin dhe trajtimin, po ashtu kanë qenë përgjegjës për këtë përmirësim në për statusin e të ushqyerit. Pra, shpresojmë që ju mund të shihni përse ne po shohim këtë përmirësim në statusin e të ushqyerit dhe si rezultati të gjithë këta faktorëve, udhëzuesit e të ushqyerit është dashur të zhvillohen për të kuptuar dhe për të pas parasysh ndryshimet që ne po shohim. Dhe dua të jap vetëm disa shembuj të këtij zhvillimi të cilit ne e kemi parë. I pari është për të parë se si ne kemi menaxhuar statusin e të ushqyerit, si të këshillojmë menaxhmentin e të ushqyerit historikisht. Rekomandimet kanë qenë shumë të gjera, kemi thënë se cilet prej pacientëve tanë që të kenë kalori të larta, yndyrëra të larta, dietë të lartë për të mos ndalë, për të shtyrë dhe rritur peshën dhe IMI, por tani në modulatorët e tanishëm dhe në kohën që ne e gjejmë veten, jemi të interesuar të mësojmë sa më shumë për trajtimet individuale, jo secili pacient apo person do të kërkohet me kalori të larta apo diet me yndyrra të larta dhe kjo reflektohet në udhëzuesin të fundit ndërkombëtar nga SBA që sugjerojnë që njerëzit që fillojnë të shohin ngritje në BMI kanë funksionim të qëndrueshëm të mushkërive dhe mund të shohin për zvogëlim, por duke pas parasysh kaloritë që marrin dhe pozicionojmë shpërndarjen e dietës së tillë të yndyrrave dhe natyrisht ky parim është përdorur në SBA dhe shohim ndryshimet në prevalencë të personave së paku në SBA. Vetëm pak të shpjegojmë që ky ndrym që shohim në FC nuk është vetëm tek modulatorët. Dhe kjo është diçka që unë e bisedoj shpesh. Shifni, ka një dëshmi të qartë që një marrëdhënie mes përdorimit modulatorëve dhe përmirësimit në peshë, shohim nga rishikimet sistematike, analizat, dhe kur e shohim në dhënat holumtuese, por po ashtu e shohim në të dhënat e reja që vijnë nga studimet e vërteta. Duke parë regjistrat, raportet e regjistrave, për shembull, studim premtues në SBA tregon marrëdhënien mes përmirësimit dhe rritjes së peshës. Si do të qoftë, kjo nuk është arsye vetme që shohim përmirësim të nutricionit. Kjo mund të ilustrohet kur e shikoni të dhënat e SBA-s, kjo ju tregon se çka ka ndodhur në SBA gjatë 20 viteve të fundit, pikat e verdha përfaqësojnë njerëzit që janë me mbi peshë, ato të kaltra paraqesin ata që janë nën peshë dhe këto të herta ata që janë në mes. Pra çka mund të shohim pas parasysh kohën në 20 vitet e fundit, shohim një ndrym shumë domethënës nga vitet 2000 kur shumica e njerëzve janë nën peshë, disa njerëz janë mbi peshë dhe disa të tjerë janë obez. Pra në 20 vitet e fundit një ndrym i madh është proporcional në shumicën e njerëzve që janë me mbi peshë dhe më pak nën peshë, që s'kemi parë më shumë janë me nën peshë dhe obez. Është e rëndësishme kur shikoni ETI është bërë disponueshme në SBA, mund të shihni që këto ndryshime në statusin e të ushqyerit kanë ndodhur shumë më përpara se paraqitjes së ETI. Ndoshta këto kanë përshpejtu këto ndryshime dhe në periudhat e ardhshme, por shumë e qartë që këto përmirësime nuk janë vetëm përgjese nga ana modulatorëve. Pra dieta me kalori të lartë ende rekomandohet për ata me statusin e të ushqyerit, por tani jetojmë në një botë ku në fakt kemi sigurimin të ushqimore dhe mbështetje të atyre që janë me nën peshë dhe po ashtu që kanë kalori të tepërta dhe ndoshta janë edhe obez dhe se këto simptoma duhet të jetojnë me njëri tjetrin. Pra ky është ndryshimi i parë, evolucioni i parë, duhet shkojmë të kemi menaxhim më të gjerë tek një menaxhim më individual, po ashtu kemi për të ndryshuar dhe bërë më fleksibil në menaxhimin e ushqyerit. Pra në të kaluarën ne jemi fokusuar në arritjen e BMI. Kjo është shumë e fokusuar, si do qoftë rritje të dhënave të rritura sugjerojnë që BMI mund të ketë paraqes statusin e të ushqyerit dhe ka kufizime dhe se është zhvilluar në dekadën e fundit në përbërjen trupore, si sugjeron se në fakt ne mund të shohim një marrëdhënie më të fortë me masën trupore, me masën muskulore për të pas ulje të peshës. Pra fokusi ynë mund të mos jetë më tutje gjithmonë në BMI, por ndoshta në optimizimin e përbërjes trupore për përmirësuar rezultatet shëndetësore. Pra duhet të bëhemi më fleksibil me caqet tona dhe në planet e trajtimit po ashtu. Për shkak se jam shumë i sigurt që të gjithë e mbani mend, fokusi ka qenë në sasinë e kalorive e yndyrrave janë ashtu fokusuara. Si do të qoftë, ne duhet të jemi më të përgjithshëm përse presim një gjatësi më të gjatë dhe se kjo mes vendeve, mes kontinenteve, por krejt çështja është për të përmirësuar dhe në mënyrë domethënëse pritjet jetësore dhe për këtë arsye ne duhet të jemi më të kujdesshëm për pasojat e mundshme të jetëgjatësisë që mund të ndodhë, siç është presioni i lartë i gjakut, sëmundjet e zemrës, situatat e onkologjike, duhet jemi kujdesshëm jo vetëm për sasitë e kalorisë, por edhe cilësinë e kalorive, po ashtu. Pra fokusi duhet të jetë jo vetëm në dietën me yndyrra, por me të pasur në fibra dhe diversitet po ashtu. Dhe përfundimisht ka dhe një fushë tjetër, dhe kjo ka të bëjë me mendje më të hapur, me mundësitë që historikisht ne si kemi menduar si të mundshme. Përsëri, historikisht në të kaluarën shumica njerëzve që kemi parë me pamjeftueshmëri pankreatike dhe të menduarit 40 vite, 50 vite më përpara që pankreasi është dëmtu, pakthyeshëm në këtë pikë. Asnjëherë s'kemi pritur që të ketë ndonjë përkeqësim, sidoqoftë duhet të jemi më mendje më të hapur sepse ka qenë cilësi kryesore që kemi studiuar, ka sugjeruar që tek fëmijët e vjetër munden të ketë përmirësim apo zgjidhje të pamjeftueshmërisë pankreatike. Dhe sa i përket kësaj, kjo është vërtet zhvillu, duhet jemi me mendje të hapur sa i përket monitorimit të gjendjes pankreatike tek njerëzit që kanë marrë terapi dhe mbajmë një sy afër gjatë për situatën. Gjithë duhet jemi me mendje të hapur për mundësi me gjendjes së vitaminave. Përsëri historikisht kemi parë pamjeftueshmëri të vitaminave në shumicën e pacientëve tanë, për këtë arsye mbajmë enzimat pankreatike me suplemente, por në mënyrë të rritur, themi jo vetëm raportet e rasteve, por studime në shkallë të gjerë sugjerojnë nivelet e larta të vitaminës A, E që i shohim në popullat, pra duhet jemi me mendje të hapur që jo vetëm për nivelet e ultra, por edhe nivelet e larta. Po ashtu. Pra shpresojmë që ju mund të shihni evoluimin e udhëzuesve të ushqyrit, duhet të bëhemi më individual në menaxhimin tonë nutricional, duhet jemi më fleksibil dhe caqet tona më të anshëm në anën e menaxhimit të kujdesit të ushqyrit, me mendje të hapur për mundësitë e ndryshimeve. Pra, kam treguar evoluimin në disa minuta dhe deshta të theksoj prioritetet kryesore që i shohim që të ushqyrit ecë përpara. Dhe unë do të sugjeroj që zbatimi i udhëzuesve më të fundit të ushqyrit tek CF Evropian, FCO Evropian është bërë me udhëzuesit më të mirë, janë ata që i kemi implementuar, ata që janë më relevantë dhe të zbatueshëm për situatat dhe rajonin tonë. Ka 16 kapituj të ndryshëm dhe duhet të propozoj 4 prioritete kryesore, 4 fusha që janë për të fokusuar në vlerësimin e të ushqyrit, në gjendjen e vitaminave, pamjeftueshmërinë e enzimave pankreatike, menaxhimin dhe për të zbatuar menaxhimin e duhur të ushqyrit. Pra në shpejt do të shkojnë për këto. Së pari duhet me siguru themelimin e një vlerësimi të mirë të ushqyrit, po ka të bëjmë me kontrollimin e peshës, kohëgjatësisë dhe BMI tek pacientët, por po ashtu edhe masat e tjera tek fëmijët për të siguruar një vlerësim gjithë përfshirës në gjendjen e të ushqyrit, duke mbajtur në mend përbërjen trupore. Kjo s'do të thotë që duhet me pas izotope apo mund të matet me konferenca të ndryshme dhe përdorimit dhënave të OBSH-s që identifikojnë kesh ushqyrit në kontekst të BMI, mbani në mend rëndësinë e përdorimit të parental sentile për të identifikuar mundësitë gjenetike që mund të identifikojmë atë ç'dim që ka të bëjë me pacientët dhe po ashtu sigurimi që ne mund të shohim pamjet trupore edhe tek personat e tjerë dhe jam shumë i sigurt që do të dëgjoni për këtë më vonë. Sugjerohet shpeshtësia e monitorimit të foshnjeve, observime më të shpeshta dhe matjes së fëmijëve dhe edhe të rriturve po ashtu. Pra vlerësimi, themelimi të kësaj ka të bëjë me pjesën kur kjo është një prioritet kryesor, pra e dyta ka të bëjë me mbështetjen të ushqyrit dhe edhe pse në BMI drejtimi dhe lloji i mbështetjes të ushqyrit mundet ende të bazohet në bazë të gjerë në BMI, pra nëse shohim BMI mbi 50, s'ka nevojë që të më thonë thjesht duhet fokusohemi në cilësinë e të ushqyrit dhe mbështetjes shëndetit afatgjatë të ushqyrit. Nëse shohim BMI nën 50, kjo është një dëshmi që ne duhet të ndërhyjmë. Kjo përfshin suplementet dhe rastet më të rënda të ushqyrit, gastrostomisë apo mbështetje të ushqyrit për të ndihmuar. Duhet të marrim
të nevojshme për personat të cilat fitojnë peshë më shumë. Pra këto janë temat dyta, në optimizimi i mbështetjes të ushqyerit. Menaxhimi i pamjaftueshëm i pankreatit. sugjerojnë pra dhe doza e enzimeve pankreatike përcaktohet në udhëzuesin e BE-s, mirë po si rivlerësim për ata të cilët kanë pamjaftueshmëri pankreatike dhe ata që janë në modulator do të jetë shumë e rëndësishme që t'i kërkohet për ndryshime. Pra, keni parasysh edhe statusin apo gjendjen e vitaminave të tyre. Pra, dozat janë të përcaktuara në udhëzuesin e BE-s, po ashtu duhet që t'ju kushtoni vëmendje frigiditetit të nivelit të vitaminave. Që kur shikoni statusin e mikro të ushqyrit, pra, duhet që të marrin parasysh edhe pjesën fizike dhe vlerësimin e marrjes së vitaminave. Pra, kombinime e këtyre na ndihmojnë që ta identifikojmë statusin e tyre të vitaminave, gjendjen e tyre të vitaminave. Pra, këto janë fragjile dhe në mungesë të një për të parë, për të nxjerrë rezultate të sakta. Pra këto janë katër prioritetet kryesore për menaxhimin e pacientëve tonë që kemi në kujdes. Optimizimi dhe përcaktimi e vlerësimit të ushqyeshmërisë së tyre, prioritizimi i tyre në bazë të BMI-s, menaxhimin e pankreatik të tyre, mbështetja e tyre në të ushqyer, si dhe të ndihmojmë ata. Pra, faleminderit shumë, se çfarë kemi disa lloje të udhëzuesve të cilat ekzistojnë në Amerikën Jugore, Veriore, në Australi, dhe këto udhëzime janë vërtet të rëndësishme që t'i keni parasysh. Sigurisht që duhet, për shkak të përmirësimeve që i shohim në global, duhet i kushtojmë rëndësi evolimit të këtyre. Të jemi më shumë më individual me ta, të jemi më të hapur me ta, me ndryshimet që na ofrohen. Dhe shpresoj që ju kam treguar këto prioritetet kryesore që na duhet që ta optimizojmë, do të thotë, për të rinjët dhe të zbatojmë në të ardhmen tonë, do të thotë gjatë aplikimit të detyrës tonë. Faleminderit shumë për vëmendjen tuaj. Faleminderit shumë për prezantimin tuaj të shkëlqyeshëm dhe mjaft interesant, me të dhëna mjaft interesante. Tani jam duke po e ftoj Sonja Graciano nga Italia që të bëj prezantimin e saj për nuk ka shëndet pa shëndetin mendor, temën e saj. Atëherë, mirë se erdhët të gjithë dhe faleminderit për ftesën tuaj që të marr pjesë në këtë konferencë. Është kënaqësi për mua që të jam këtu sot. Jam psikologe e klinikës dhe punoj në spitalin Bambino Gesù, spitalin në Romë. Jam bashkëkryesuese e grupit evropian që punon në shëndetin mendor dhe jam edhe antare e grupit të mendetit shëndor në SBA. Pika e parë që duhet të kemi parasysh në rrugtimin tonë sot është që ne nuk kemi shëndet nëse nuk kemi shëndet mendor të mirë. E dim që menaxhimi i fibrozës cystike është mjaft me mjaft pengesa dhe kjo rrit nevojët që
To build a framework for mental health in CF, it is important to consider some premises. The first one is that our well-being includes both physical and mental health. This means that we need to treat the whole person in a chronic condition. There is growing evidence in individuals with cystic fibrosis and any chronic disease that they are at higher risk for anxiety and depression. So the second premise we need to keep in mind is that we have valid tools to measure psychological symptoms. And the third one is that if you have a chronic disease or if you care for a chronic child, if you care for a child with chronic disease, feelings of depression and anxiety are normal responses to a challenging situation. Importantly, these feelings affect your behavior. But what is depression? Just to keep in mind, depression is a prevalent mental health issue that adversely impacts your emotion, thoughts, and behaviors. Unlikely temporary sadness, clinical depression can persist for weeks, months, or even years without treatment. Those affected may feel hopeless, lose interest in activities, difficult with eating and sleeping. And what is anxiety? Anxiety is a natural emotion that can come and go in response to worry about such things as changes in health, work, relationship, money. A person may have an anxiety disorder if the anxiety does not go away, get worse or over time, and prevents them from participating in ordinary daily activity. In addition to the general anxiety, what we can see every day in our CF clinic is a specific anxiety, which is the procedural anxiety. This is a very important study. This is the TIDE study, and in CF, in fact, the international TIDE study published in 2015 showed high rates of anxiety and depression in children and parents. These rates were 2 to 3 times upper than in the general population. Based on these results, International Committee on Mental Health developed specific guidelines to address mental health. This is another interesting results of the TIDE study. They found that when a parent has depression, the probability for the child to have depression is more higher. And this is true also in the opposite way for anxiety and depression. So this means that annual screening of psychological symptoms is needed, and they are recommended by the mental health guidelines. Here you can see the map that any psychologist or any medical doctor can follow for the screening process and to build the intervention. The intervention is based on the range of the screening, so we can have mild, moderate, or severe anxiety and depression. And based on the screening, we can have a supportive intervention, we can do a clinical assessment, we can also start evidence-based psychological or psychopharmacological intervention, because in some cases psychological intervention is not enough. So sometimes we need to combine the psychological intervention with psychiatric medication. So this, in this slide, you can see the two screening measures. These screening measures are very simple and are easily to manage. You just need 5 minutes. It's like a blood test. And the main point is that these measures are free, available in more languages, and of course, if some country don't have this measure in their own language, so we can also organize translation following the FDA and EMA guidelines. So the PHQ-9 and GAD-7 identify the presence and the severity of anxiety and depression. Recommended intervention are based, as I told you, on severity. So in case of mild depression, we can just do educational intervention and rescreen at the next visit. In case of moderate depression, it's very important to organized psychological intervention. And in cases of very severe symptoms, we need to involve a psychiatric for consultation. But why, sorry. It's so important to screen and identify anxiety and depression. We know that anxiety and depression are linked with adherence, with clinical attendance, health outcomes, systematic inflammation, and we have a study published a few years ago that depression is linked with early mortality, and of course is linked with quality of life. So TIDES put mental health on the map for CF care. So, and after this study, many studies were conducted to disseminate the new mental health guidelines. We also know that mental health screening is an intervention itself and provides motivation to pursue mental health support. So it's just a way to open the box on mental health. It's not a diagnostic measure, but is a way to start to open a conversation with your patient about mental health. Also, we know that CF patient and caregiver view mental health screening as an important part of CF care. So recognizing mental health challenges help to address the needs for people with CF. These reflections are also important in the area of neuromodulator. We know that after the initiation of the neuromodulators, we found an association between the starting and some mental health problems. We know that the neuromodulators are very effective. We know that we have improvement in FEV1, in BMIs with chlorides, and the health-related quality of life. Despite these great results, we are dealing with some problems and challenges for people with CF in terms of mental health. In particular, as you can see in this slide, neuropsychiatric side effects have been reported for all available CFTR modulators, and alteration in mood, anxiety, sleep, and neurocognition, as well as suicidal ideation was reported. In fact, the Pharmacovigilance Risk Assessment Committee for the European Commission recently determined that there is at least a reasonable possibility of a causal relation between ETI and depression. So people with CF and their family should be encouraged from all of you, not just psychologists, to report both positive and adverse experience with the new modulator. So this is a way to find some solution and help them with some that can be challenges. So mental health, these suggestions are in the standard of care for CF. Mental health should be monitored with accordance with the ECFS and CFF guidelines, including screening for depression and anxiety before and no later than 3 months after starting the new modulator. So we know that several case series and single-center studies have documented the side effects related to starting the new modulators, including cognitive fogging, difficulty with memory and concentration, headaches, insomnia, and negative body image. And you can find in the Journal of CF just a new paper with a review of all of these papers. Based on the standard of care recommendation, I'm going to show some results of a study we did in our center at the Bambino Gesù Children's Hospital, which is published on CHEST. This is a real-world study to evaluate the effect of EDI on the whole person, collecting pre-post assessment and follow-up data. In those blue bubble, you can see the measure we chose, and we chose a broad-based assessment including clinical outcomes, psychological symptoms, cognitive processing, side effects, GI symptoms. We did a specific measure with Dr. Alghisi, and health-related quality of life. So significant, I was so fast. So significant improvement were found in FEV1, BMI, depression, cognitive processing, some GI symptoms, and most health-related quality of life domains. And these data were very similar to the pivotal trials. Interesting, depression and anxiety at baselines were more than 10 points lower than those reported in a study conducted in 2020 in the same center. Probably linked with the optimism, linked to start a new modulators, and of course there was a big expectation about a possibility to start a new life. Interesting, despite all the good results in terms of clinical parameters, we found some side effects in our population. They reported insomnia, headache, memory problems, brain fog, concentration problem, and they occurred in 10 to 29% with not improvement over time. And interesting, women reported more side effects than men. We don't know why. Probably this is linked with the estrogen, but of course we need more study to better understand this relationship. These are some results based on a survey we distributed in Europe through the European Cystic Fibrosis Society, and we can see the confirmation of some problems in sleep difficulties. These are results based on the report of the providers. In this second slide, you can see the prevalence of some concentration and memory problem that were found in 1 to 20% in all the type of centers, pediatric, adults, and combined. After this survey was distributed and published, you can find it on pediatric pulmonology, we adapted the same survey and we distributed it in Europe. We are writing the paper, so probably we will have the results very soon. We had 78 respondents from 21 countries in Europe, so this is very representative. And what we found was similar percentages of positive physical and psychological effects, as well as side effects related to sleep and cognition. When we compare Europe versus the US. We had fewer negative mental health effects like increased depression, suicidal ideation, and concern about the future in Europe compared to the US. Probably these results may be explained by the differences in the healthcare system and the social safety nets. So after this journey, do you think it will be important to screen children? Please raise your hand. Thank you. So we think it's important as a mental health community in CF. We think it's very important. We think it's very important to screen anxiety, depression, and other aspects in children. And we are dealing with the fact that when the TIDES was published, we didn't have specific guidelines for...
You have to respect the time, excuse me. Do you have any more slides? Because we're a bit late.
Can you very close to that.
Wrap up, please. Thank you.
We didn't have specific guidelines for mental health for children under than 12. In 2020, the US Parental Task Force recommended screening for all children for anxiety and depression starting at age 8. In addition, with the introduction of ETI, we know that concerns have emerged about side effects. We know that ETI in children is highly effective, but at the same time, we are wondering also about the development and mental health. In this slide, you can see just two drawn by two one young boy and one young girl on the effect of ETI. So there is no doubt that these drugs is very, very effective. At the same time, I want to show briefly a couple of slides on some concerns we have on possible side effects. This is a study published by Sermet and colleague in France. And as you can see, we can have sleep changes, ADHD, irritability, and abnormal sadness in children who started ETI. We don't have very clear results on this topic. For example, in these other two studies, we have some contradiction. For example, in the first study, 10% of adolescents have depression and anxiety, and also sleep concerns, but in the second one, they didn't find any change on mental health. So this is the reason why TIDES 2.0 was approved, and this study was founded in the US. You can see the main point of the study, and 16 centers will be participate in this study, and now we are planning to extend the study in Europe. This is the entire protocol. Don't be afraid, because if you want to participate in the study, we can simplify the protocol, and we can just do a one-point assessment instead of 3 times of assessment. So this is the core group of the distribution of this new project in Europe. We have European and Americans in the group, and we will be very, very happy if also the Eastern European country can be included in the study. So thank you very much.
Thank you very much, Sonia, for this interesting presentation about the mental health and mental psychological problems encountered during the ETI period using of modulators. Very interesting. Thank you very much.
Thank you.
Faleminderit të gjithëve.
Thanks to everyone.
A quick picture with trophies for all the speakers and then run to the lunch hall.
Foto.
Test, test. Test, test, test. Test. Test, test, test.
So if you have rested a bit and had a small relax after the lunch, with the next sessions.
With next speaker, Pavel Dravinek from Czech Republic, presenting innovative molecules in CF therapy. Please.
All right, good afternoon. So we've heard already several times the term CFTR modulators. So I think, and we all think, that it's now a good time actually to introduce CFTR modulators and give more explanation to these molecules. The title of my talk is Innovative Molecules, but that's more or less the synonym to the cystic fibrosis transmembrane regulator modulators. So let's start from the very basics. CFTR, cystic fibrosis transmembrane regulator, is, in other words, chloride ion channel. And this is the key to the innovative treatment of cystic fibrosis. When we are talking about the CFTR protein, it's a rather complicated structure. It's got 5 domains. Some of them are intramembrane, some of them are regulatory or binding ATP. So for the purpose of my talk, I will simplify this, and for clarity, I will use this picture representing the chloride ion channel with the major function, which is pumping in or out chloride and other ions. All proteins are encoded by genes. So of course, in our genome, there are the genes encoding cystic fibrosis CFTR protein. The gene is pretty long and also complicated. We've got 2 copies of the CFTR gene, and cystic fibrosis, the disease, is caused when both gene copies are mutated. So, give some examples of mutations. The most common mutations worldwide is mutation F508del. So what's going on the gene level? There is something wrong, let's say in the middle of the gene, and this is actually the loss of 3 base pairs, of 3 nucleotides. And on the protein level, what happens is that there is the deletion and loss of 1 single amino acid. But this means huge consequences on the term of the functionality of the CFTR protein. So there is no functional protein on the membrane level. Actually, what happens with this mutation is that the protein or its basic structure is only intracellularly and no proteins are on the membranes. Another example, another mutation, G551D. Again, there is a mutation in the gene on a very similar location like the previous mutation, but this time something different happens to the CFTR protein, and it is the change of 1 amino acid. So it's not the deletion, it's the substitution of 1 amino acid with another. What are the consequences? Not functional CFTR protein, but CFTR protein is present on the membrane. So from this perspective, is a little bit better condition than the previous one. We've got the protein on the membrane, but the protein is not functional. Another, the last example, mutation G542X. This mutation is also called stop codon mutation, or a premature termination of the translation of the protein. So what happens with this mutation? There is actually no translation of the protein, so we have no protein, but the protein can be found even intracellularly. There are no traces of the protein in the cell. So we've got the membrane without CFTR. So put this all together. So I just introduced 3 examples of 3 types of mutations, and they are good representatives of functional classes, class 1, class 2, class 3. But we've got more classes. We've got class 4, which means that there is a CFTR protein on the membrane, but the conductivity is not ideal. Class 5, we have proteins, functional proteins on the membrane, but not in high enough quantity. So there is not the good number of proteins on the membrane. Let's make an intermezzo and introduce CFTR modulators. We've got two groups of CFTR modulators. One group called potentiators, and their goal is to open the CFTR protein. So when I use the same pictures, which I introduce in terms of the mutations, so there is the example that the protein is on the membrane, it's not functional, but potentiators can change their function and can actually turn it up to be functional. Correctors is another group of CFTR modulators, and correctors increase the number of CFTR proteins. So they rescue the protein which is intracellularly and help it get to the membrane. And from this picture you can already see that one of the ideas and mechanism of action of the CFTR modulators is the combination of correctors and potentiators for most of situations. The molecules which are potentiators, we've got so far two, ivacaftor and deltivacaftor. From correctors, we know 4 correctors, lumacaftor, tezacaftor, and the next generation correctors, alexacaftor and vanzacaftor. So now, to summarize the first part of the talk, so we have 5 classes of mutations. We've got actually more than 5, but we've got many different types of mutations, and we can classify them into the functional classes. And we've got the CFTR modulators. So what is the situation, how we actually apply CFTR modulators to those mutations? And I will now follow the situation in Europe, so how European Medicine Agency approved the treatment options and the use of CFTR modulators from the 2012, when the era of modulators was open, until today. So we want actually to make the CFTR protein functional. So we started in 2012 with one of those molecules. It was ivacaftor, and ivacaftor worked fine for the class 3 mutations. We've got several options how to actually rescue the situation with the class 2 mutations, with the common mutation F508del. So we could use the combination of lumacaftor, ivacaftor, or tezacaftor, ivacaftor, or triple combination, alexa, teza, ivacaftor. But some of these combinations work only for patients who had both copies with F508del, and the triple combination worked also for situations where there was a single copy of this mutation. And for class 4, class 5 mutations, we could use tezacaftor, ivacaftor. One of the take-home messages from this picture is that there is class 1 mutation, and it is not rescuable by the modulator drugs because there is no protein available to be rescued. So why we've got so many options, so why we've got several options of the modulator drugs? One of the reasons is that there was the entrance to the market in different years. It all started in 2012. We had ivacaftor under the brand name of Kalydeco. In 2015, we had this combination of lumacaftor, ivacaftor with the brand name of Orkambi, then tezacaftor, ivacaftor, Simkevi, and in 2019, the triple combination was introduced, alexa, teza, ivacaftor, under the brand name of Trikafta, or Kaftrio in European Union. Another reason why we got more of them is that they are different in terms of the efficacy. When we measure some of the classical parameters of the clinical effectiveness, we use one of the spirometric measures, which is the FEV1 value, and the value of sweat chloride, of the concentration of chlorides in sweat. And we can see, for instance, when you look on the right, that there is a clear difference between the therapy with Orkambi versus Kaftrio. So the the change of FEV1 is much higher when you use Kaftrio compared to Orkambi, and the same can be applied to the changes of the concentration of chlorides in sweat. So what happened very recently? European Registration Agency, EMA, just announced in February this year that Kaftrio, the triple combination, can be used for more patients according to mutations, and they changed the indication criteria saying that Kaftrio is indicated to all patients of the age 2 and more who have different mutations than class 1. It's quite tricky, actually. It sounds very easy, but it's quite tricky in a way. What are the mutations of class 1? And I will encourage you to ask Professor Macek on Saturday morning, because he will give you the talk on genetics, what is actually the class 1 mutations. Okay, back to this picture. So what's the EMA new indication criteria mean in this picture? So it means that we can use the triple combination Alexa, Ivacaftor for all the classes of mutations except for class 1 mutation. This year we also witnessed the entrance into the market of the new molecule, of the new combination. We sometimes call it a new Kaftrio. It is triple combination with Vanzacaftor, Tezacaftor, and Deutivacaftor, and you can see what are the differences. One of the correctors is different, and the potentiator is now Deutivacaftor instead of Ivacaftor. One of the big advantages in the dosage regime is that this drug can be given just once per day. What are the clinical trial data showing with Vanzacaftor, Tezacaftor, Ivacaftor, Deutivacaftor compared to the Kaftrio? People were checked for 1 year, 52 weeks, and 2 groups of patients were checked. The one of them were patients with a single copy of mutation F508 delta. And when we focus on those 2 basic parameters, spirometry and sweat test, we can see that there are no differences in FEV change. So patients on Kaftrio had very similar values like people on this new triple combination. But in terms of sweat tests, we can see that there is a difference. Actually, people on the new triple combination had lower values of the concentration of chlorides in sweat compared to people with Kaftrio. So the conclusions were that the new combination is more efficacious, at least in terms of the sweat chloride. The other group of patients, which was also checked, were the patients homozygous for F508del, and there was more or less, the results were copied, with the only difference that the sweat tests were a little bit, there was not such huge difference in the reduction of the concentration of chlorides. So this triple combination was approved in America. So the FDA agency put it into the list of approved medication at the end of the last year under the brand name of Aliftrek. So in conclusion, so let's conclude first what's on the European market available. We know that the indications of new molecules